Hey, everybody.
Hey, guys.
We'll go ahead and get started in a second. We plan is to just kind of run through all of the high yield material for your exam on Monday, I believe. So if you've watched the previous reviews that we've posted on YouTube for the previous terms, this will be similar. We're going to use the same slides. They teach all the same stuff as them. So if you have seen those, this will be similar. But obviously, we will answer questions for you guys as we go. Did you have anything you wanted to add, Lindsey?
Nope.
Nope. Okay.
Yeah, no.
Fantastic. We'll try not to keep y'all too long, but it's just a lot of material. So we'll take breaks. Let me share my screen. So a couple of the housekeeping stuff. Lindsey and I are, well, so these reviews are not affiliated with school and not affiliated with DES or anything like that. So we have officially changed our names. I'm Scrubs, Lindsey, it's Dog Mom. What is it, education? How's it go?
Med Ed.
Med Ed.
Med Ed.
And of course, Kishore, y'all know Kishore by now. He runs Here's the Tea. Anyway, just to let y'all know, it's not under DES's name, but I pulled this up to show you. Obviously, we post everything here, all the slides and the links to the reviews. But if you're looking for the YouTube channel, we keep it private just because we want this to be for SGU students. So you have to click the link. Once you bookmark the link, it will bring you here. This is the term one playlist. This is whoops. This is all whoops, that's weird. Okay. These are all the reviews we've done there. So the newest ones are on top, but this is a good thing for you guys. Like when you get into MSK, right, you can watch some of the older reviews ahead of time if you want, just because this one ends up being so close to the exam. These are very similar. This is very similar to the one we ran in for the April class. So if y'all want to get ahead and kind of, some people I've heard watch it incrementally, like on the weekend, every weekend they'll watch a little piece of it just to kind of go along with it. But it's up to you guys. But anyway, everything's here. So if you bookmark the page, you can get to it. Also, again, this is not affiliated with school or anything, but IEA is the honor society at SGU. You should follow us on Instagram. We post a bunch of updates and stuff. Like for instance here, the IEA tutoring is now available. The link is in the bio section on Instagram. Also, I posted it on the class pages. You can sign up to get a tutoring session with one of the upper term honor students. They could kind of look at the way you study and stuff like that and maybe fine tune your process. So you could sign up for that. We're going to start that next week or the week after. So it's a good opportunity just to have someone kind of look and see like what you're doing and maybe can point out a few things that that'll help. All right. Now, if you didn't do as well as you wanted on the first exam, that's okay. This is all a learning experience. Sometimes you have to see what doesn't work to figure out what works, okay? So I always preach, the more you can understand, the less you have to memorize. The things that failed me on a test are the tables I had to memorize, right? When you're under stressful circumstances, the things you can understand are the things you retain. You're going to want to retain a lot of this going forward because it gets more complex as you go. So the things you can work out that you can explain to another person that you can understand, the better off you'll be. And I know that's easier said than done, but sometimes it's okay to take a little extra time and just kind of work through like, what's the process going on, okay? That's why some of the extra resources like Boards and Beyond and stuff is good at explaining things like that. Also, the best correlation to how well you're gonna do on exams is how many practice questions you do, okay? So it's not just doing the practice questions, there's an art to doing them, right? So it's just like playing sports is the analogy I use. You get better, you get more confident, you get faster. So you definitely want to do a bunch of practice questions. Now, even if you don't feel 100% comfortable with the material, it's a good thing to start doing practice questions anyway. It's okay to get them wrong as long as you're learning through the process, okay? So I know a lot of people want to wait and do questions last, but sometimes it's just not that convenient, right? You need to just start doing them and use them as a learning tool. All right. So this is informal. I don't keep the chat up because it's distracting. So if you have a question, just speak up and say something and we'll go over it. You won't hurt my feelings. All right. Again, we need to change these slides. It's Scrubs now and Dog Mom. And then as always, we put our additional resources on our Google Drives. Make sure you go look at this because there's a bunch of extra questions and just stuff we found helpful going through. So I update this as we go along, but it's definitely good to take a few minutes to go see if there's anything you like in there, because we do collect a lot of things from a lot of different resources. All right. These links, y'all should have gotten access to these. Dr. Sobering goes through these different situations. I think if they're quick little videos, and if you can go through these and just understand, the process, I don't think they'll get much more complicated than these videos, right? So one of the things about doing population genetics, it can get very complicated, but when it gets complicated, you need to be able to write it down. So the school understands the fact that we don't have whiteboards right now, so they keep these questions fairly straightforward so you can do them in your head. There's a couple of tricks that you need to be aware of that we're going to go through to be able to answer these questions because, well, I should have a caveat. Dr. Sobering doesn't teach this anymore. He was one of our favorite teachers, but it's still the same principle. I know Dr. Mpadya is teaching y'all now, but it's the same principle. They use the same guidelines and stuff, but he was one of the genetics teachers here before. Anyway, but it's all the same, okay? Now, there is difference between the allele frequency versus, or the phenotypic frequency versus the genetic frequency. Remember, depending on how the gene is transmitted, whether it's autosomal dominant or autosomal recessive or X-linked, the phenotypic, you can't necessarily tell the genotype from the phenotype, right? Because some determinants are going to be whether it's recessive or whether it's dominant, right? So the only thing they're trying to do here is to show you that there is a split, and you can see the math here. So even though if you use the Hardy-Weinberg equation, it would work out that in a population you had 64 homozygous normal versus 32 that would have MN, and then 4 would be autosomal recessive, right? So these would be the heterozygotes. But if you work this out, you still can figure out that there's 80% large N versus 20% small N. Now, this just comes into, this is just a precursor to what we're going to be looking at in a second, but this will help you to determine not only the genetic or phenotypic frequency, but what is the allele frequency. So each of these is a separate allele in the population, right? So just because the phenotype or even genotype, or excuse me, just because the phenotype is one thing, it doesn't necessarily mean you could figure out the allele frequency unless you know that the disease is dominant or recessive. But in the questions, they'll give you that. So we'll go through it in a second here. So this is the equation that they use. Typically, we use P as the dominant type, Q would be the recessive type, and then the heterozygous would fall under 2PQ. What I actually, and you could actually use this equation along with this equation, and that will help you figure out, basically, if you have one, you can figure out the other, right? Because once you work it out here, it's just going to be the additive. So if you know P, you could figure out Q because they have to equal 1, okay? So we'll go through some of these practice problems. If you understand the problems we're going to do here, you should be good on the exam. All right, so same thing here. This is the Hardy-Weinberg equation that y'all are familiar with. And then this is from first aid. I always preach this, the sooner you start looking at first aid, the better. So it's kind of like after you have all this information from lecture, just jump into first aid and be like, okay, what are they definitively saying is super important? Well, okay, so we could figure out the Hardy-Weinberg equation here, but also these assumptions that we take in, right? So this means it's a completely random selection, right? So you're not incurring any mutations that come along with it. And that has to be a set standard for the Hardy-Weinberg because there's no external variables coming in. So this is just an example of what first aid would think is important. Now, for the sake of time, you can do this on your own. I just wanted to show you how the math actually worked out. So we're gonna do this quickly, but it's not as important as the summary slide I have, but I just wanted to show you how this works out. So like I mentioned, we typically use P as the homozygous normal, the heterozygotes and the homozygotes. So this is typically how it works out in a population, right? Yeah, sure.
So if Q is less than 5% of the population, we can assume P is 1. Is there going to be like a test, like on the test, do they not tell you Q is more than 5%, or is that always going to be like that?
I've never seen a question where they didn't make that assumption. You really have to make that assumption in these equations just because it gets way too complicated if you don't. I've never
Okay.
seen them vary
Okay.
from that.
Thank
Yeah.
you.
And I'll talk about it in a second. Yeah. All right. So for autosomal recessive, what are we talking about? Remember, I said that Q is going to be our autosomal recessive type. Obviously, the heterozygotes don't count because we're talking about autosomal recessive. So if you work out the incidence, Q squared will equal the incidence rate. So if you work out, that means Q equals the square root of I. Do you need to know how this works out? Not really. The point I want to make is that this is how it does work out. So you need to know the incidence rate for autosomal recessive is the square root of I. They test autosomal recessive diseases 10 times more than they test everything else because you can use these variables that help you when you don't have a whiteboard. So if you're going to remember anything from the next 10 or 15 minutes of me talking, it's this. When it's autosomal recessive, the incidence rate of that disease will be the square root of Q. Q is saying how many people have at least a single allele that is recessive. So if you have 2 single alleles that's recessive, that would mean, let me just watch. So Q would each say you have, say a small a, right? The mutant A. So what Q squared is saying, for you to be autosomal recessive, you have to have 2 small a's. So you have to have AA. So Q equals, the incidence rate is this. This is what we're saying. You have to square it, okay? That's saying how many people, Q squared is equal how many people have both AA, which means the incidence. Also, the incidence is the same thing as saying AA, right? The incidence of this disease, of this autosomal disease, the incidence of you having this is going to be Q squared. I'm sorry, the incidence rate of this is going to be the square root, right? So Q is going to be the square root of I, or I, the same thing as saying is I equals Q squared. All right, so I hope I didn't confuse you there. But what the incidence rate is saying is incidence is how many people are autosomal recessive. Okay, so you could figure out how many autosomal recessive people there are just by knowing how many mutant alleles they are, right? So Q would equal that mutant little a. Okay, so if you know that how many little a's are in the population, then you could say, okay, if Q or this little a is how many little a's are in the population, if you take the square root of it, then you could say how many people actually have the disease. Okay, by definition, right? And you could see that here. So of all the mutant alleles, right, that single spot, right? So again, remember that the alleles, there's 2 alleles, right? So you could either be AA or heterozygous A, or you could be AA. Each one of these spots is an allele, right? So there's 2 alleles, per gene, right? Okay, so Q is going to be one of these single alleles. And if you know the single mutant allele, what the rate is, then you could figure out how many people actually are autosomal recessive, how many people have both alleles as mutant. Okay. Now you could do this for autosomal recessive carriers. So we're looking for the carrier frequency. So we're looking at this one. So again, this is going to be important to know, but by all means know the first one, that the Q is equal square root of I. And I have a summary slide coming up that has all of these. So if they ask you how many autosomal recessive carriers they are, if you know the mutant allele frequency, you could figure out how many carriers they are. Okay, all you need to know is Q. Now, can you also figure out P? Yeah, of course. Again, if they give you Q, you know P plus Q, plus Q equals 1. All right, so if they give you 1, they give you the recessive allele in population, then you know what the normal allele is going to be, okay? Because it has to equal 1. You can also figure out if they give you Q, how many autosomal recessive carriers there are by using this equation. Can you figure out, if they give you P, can you figure this out? Yes, of course, right? You use this equation first. P plus Q equals 1. So if you know P, you could figure out Q, and then you could put it into this equation. Okay, so it's the idea of just by statistical analysis, you can figure out just by knowing one allele what the population genotype will be.
Excuse me, I have a quick question.
Yes, sure.
So going back to that last slide, if wouldn't this be for autosomal dominant?
Okay, yes, and it will be the same thing, and I'll show you that coming up, and it makes sense. Give me a second and I'll explain it. It's coming up.
Okay.
Yeah.
Oh yeah,
Yeah.
well, because I was also curious, because wouldn't I have to take the square root of the incidence to get my Q and then multiply that by 2 to get my my carriers?
Yeah. So it would be, if you worked it out this way. Yeah. I'll show you. Hold on. Let me show you a second real quick.
All right.
Yeah, so this right here, so autosomal dominant, right? So same thing. Now, you may say, well, why don't we use this rate too? Okay, well, actually, for this equation, the way Dr. Sobering worked it out is, so if you are autosomal dominant, right? The vast majority of people that have an autosomal dominant are going to be this genotype. Why is that? Because the idea of you getting both parents that had the disease and you getting this are very, very slim. Okay, so because of this, statistically, you can rule these out. Now, you may also say autosomal dominant diseases are so severe in this format when you have half normal, right, and half disease, that if you had no normals in an autosomal dominant disease, that those patients tend to die sooner or have very severe phenotypic effects, right? So when we do autosomal dominant, we typically just use this one because, you know, the greater percent of people in the population that have an autosomal dominant disease will be this. Okay, so, and Dr. Sobering, Dr. Padua would have explained this, saying like, just statistically, this is so close to 0 that you just don't even need to use it. Okay, because the patients that would have to both have the disease, the mom and dad would both have to have the disease like this, and then there would be a 1/4 chance of you getting this. Okay, so it's not super likely, and that's why for autosomal dominant diseases you use this. So yes, this works out as the same equation, and you're looking at what the rate is. So either you look at autosomal recessive carriers, which would be this, or autosomal dominant, and it works out the same way. You just have to use the correct variable or the correct allele. I hope that answered your question. Now, if you do X-linked recessive, depends if it's a male or female. Why is that? Well, the men only have one chance, right? Because they have only one of the alleles has to be a Y. So they call that hemizygous. That means if the man gets only one X, the other spot has to be a Y, right? So they don't have, if you look at it, so females would have one X and one mutant X, right? And men would have one mutant X and one Y. So women will have one X that's normal. That'll make them carriers. Men don't have a normal X. The only X they have to work with is this mutant one. Okay, so that being the case, if men get a single mutation like this, they're going to have the disease. They're hemizygous. Whereas if women get the single X, there will be carriers. Okay. Right. So you could even ask yourself, so by definition here, the mother would have had to give the disease to the child in X-linked recessive diseases because they had to get Y from dad, right? You can't tell here. One of these X's came from mom and one from dad. Okay, and y'all kind of covered that in the first exam. So again, the point of this, if this is just kind of like, the point is here that you want to remember these frequencies. And again, I do have a summary slide coming up. Now, X-linked recessive, when female carriers are heterozygous, then you use this equation. And the P will be the X that's normal, and the Q will be the X that is the recessive trait, okay? So again, you're using this carrier rate. All right, and so this is the slide I wanted to show you. These are, so when they give you a problem with the incidence rate involved, this is what you're going to want to remember. You want to figure out what the allele is, what Q is going to be. What is that recessive allele? Okay, that recessive trait or that recessive allele is the best way to say it. Once you figure out that, then you could figure out the incidence rate. Remember this too, they can actually give you the incidence rate. They can give you this. They could say 1 in 200 people have the disease in this population. And they could say, what is the allele frequency? So you just work it backwards. You square both sides. So I would equal Q squared. So any way they give you, they have to give you P or Q or the incidence rate. If you have any of those, you could figure out the rest of the situation. By all means, the questions you're going to come across are autosomal recessive, okay? So you have to know this one, but I'd say any of these are fair game. Okay, so basically I just walked through the math of how they work these out, but the main thing is if it's, just to make sure that you memorize these. And as the question that was asked, you can see that autosomal recessive carriers and autosomal dominant would use the same equation, right? You're just worried about whether it's that recessive trait that's being carried along or that dominant trait that's overactivated and causing the disease.
I thought
Okay.
for the autosomal carriers, you multiply it by 2, not 1/2.
So
Like,
2p
Have the incident and
2pq would equal the incident. So you would you would assume p is 1, and then you would divide by 2. You move this 2 to the other side, right? So maybe you were thinking if you did the q. So assuming p is 1, all right. So we're so close. Recessive. Sorry. Wait. Let me just. I'm using the
someone in
dominant
the
one.
chat said if you calculate it based on the incidence from allele frequency. I think that's what I was talking about. Like if you knew Q, then the carrier weight would be 2Q. So I got confused. Sorry.
Yeah. Okay, and that's a good point actually. And I have a question coming up to point this out. I used to always forget to divide by or to multiply by Q. That's like the last step, but I'll point that out in a second when we do a practice question. So just remember, yeah, this is what we were talking about. So I had the dominant one up because it was the same equation, but we're talking about autosomal recessive. So 2pq equals the incidence. Remember, when we're talking about recessive traits like this, the recessive trait in the actual population is generally going to fall well under 5%. Like if it's just generally, even some of the common autosomal recessive diseases, well less than 5% of the people are going to have that recessive allele or that mutant allele. So it was brought up earlier, so I'll point it out now. If Q is less than 5% or 0.05, you can assume that P is 1. I've never seen a practice problem where they pointed it out that it wasn't, okay? So you can always assume P is 1. That just makes the math simpler, okay? So this is just a generalized understanding. You assume P is 1. So if P is 1, then 2Q equals the incidence. So then you divide both sides by Q, and Q equals 1/2 I, or I over 2. Okay, so just remember, in general circumstances, we assume Q is less than 5, so you can assume P equals 1. Okay, usually Q is like 0.001 or something, right? So it's like P is so close to 1 that the math's negligible. Okay, so and that's why you'd use P equals 1. All right, but let's do some practice problems and we'll work through this.
Just a question: is there
Yeah.
is the X-linked dominant the same as the X-linked recessive equations?
Not for the females, right? Because so for guys, yeah, it would have to be because they're hemizygous. So it doesn't matter. They only have one X. So if the X is mutated, whether it's recessive or dominant, you're going to have the disease. But for females, you'd have to use the carrier rate because, or I'm sorry, you use the autosomal dominant one. Because if it's still autosomal dominant for females because they have 2 spots, right? So if one X is mutated for females in an autosomal dominant, it's kind of the same thing as saying this, right? A little a, right? They have 1 mutant here and 1 normal. So this equation would work out with this. They don't really test on all X-linked dominant. I mean, not really at all, actually. So I wouldn't stress that too much. But yeah, you would treat the female as an autosomal dominant, just because, and again, it's not autosomal dominant, but the math works out the same because you have one mutant and one. Either way, they have the disease because it's a dominant trait. But for the guys, it would be the same thing for hemizygous. You get the one mutation, and you're going to get the disease. All right, but by all means, this blue slide, make sure you could just write these out, especially this one, right? This is by far, the autosomal recessive by far the most important. All right, and then they kind of talked about this, knowing, sorry, cursor, okay. Knowing these is kind of just a little extra information. They won't by not knowing this, will you not be able to answer the question, but if you do know this, that's a little extra material. Like if it comes up as soon as they say this, you know it's Tay-Sachs, right? So a lot of times they'll give you 3 or 4 little pieces, and if you could kind of put them together, right, you can definitively say. So it may be good to just commit these to memory. They'd like the Tay-Sachs when this is pretty common in there. 1 in 30, that's a big deal, right? So they ask that one a lot. All right. Now, when we talk about population genetics, we're going to do the same thing every time. This is how it works out. You want to calculate the frequency to the father, or the percentage to the father, the percent chance to the father, to the percent chance to the mother, and then the Mendelian frequency. Again, the vast majority of questions y'all are going to come across are autosomal recessive, meaning this will always be 1/4, right? Because you have, if you do the Punnett square, you get a 1/4 chance of getting little a for autosomal recessive. Okay, so these are the two rules. They love these rules right now because you don't have a whiteboard, so you should be able to read these problems, these vignettes, and be able to see definitively, like I'm reading it right now. That's the 2/3 rule. That's the 1/2 rule. And then you could fit them in. Okay, so 2/3 rule is if you have a sibling, your brother or sister has a disease, say, and these are for autosomal recessive. Again, that's why they test these a lot, because you could use these rules and you should be able to pick these out. So again, autosomal recessive, if you have a sibling with the disease, you have a 2/3 risk of being a carrier. Now, we talked about this last time. Remember, if we did the Punnett square, and this is why we did this, and they said, you brought the other child in, right? You have one child that has the disease and you brought the other child in. Why is this child a 2/3 risk of being a carrier? Well, we said this rule, remember, we can assume that if you bring a child in to see the doctor, one child has it, right? So you're bringing the other child in to see the doctor. You could definitively say at this point, they don't have the disease. They would have to tell you that in the vignette that they have the disease. Okay, so it is different if the child's still in utero, right? If the mom's pregnant, then maybe they don't know. But when they ask this, they're saying that the child has been born already. They don't have the disease. What's the chance of them being a carrier? And you could see that here, 2/3. 1/3 chance they're homozygous normal, 2/3 chance they're a carrier. So you should be able to know this as soon as you see it. They'll put it in basically these words, and you should be able to say that that child is 2/3. Okay, there's also a 1/2 rule. If you have a sibling, brother or sister, with a child that has the disease, you are a 1/2 risk of being a carrier. So basically, they're saying if you're the aunt or uncle of a child with the disease, right? So it's like 2 levels away. Here, I'll draw it out for y'all. So if this is you, if you have a sister, right? And this kid has cystic fibrosis, right? The way this works out is that you would definitively have a 1/2 chance. So you should be able to know that without looking at it. If you wanted to just break it down, if this child is cystic fibrosis and AA, you would make the assumption that both parents, because they'd have to tell you if one of the parents had the disease, right? They would have to color it in. So if they're not colored in like that, you could assume both parents are carriers, okay? So that would mean that the father is definitively a carrier. So since they share one half of their DNA. Brothers and sisters share one half of their DNA from the parents. That means you are a 1/2 chance of being a carrier, okay? So don't make these two more complicated than they need to be. Why did I know that both of these parents were carriers? Because they didn't color in these boxes, right? If they colored it in, they would be telling me one of the parents has cystic fibrosis. People with CF don't tend to be able to, they don't have a high reproductive fitness because of their disease. But generally, if you know this, then you know both parents are carriers. If that's the case, then the aunt or uncle has a 1/2 chance. All right.
Remember,
All right.
just to private message Brady or myself with your answers to give everyone a chance to answer unbiased.
Try to do these in your head too, right? Because you're not going to have you're not going to have paper, but try to use the tricks that we just talked about. I'll work that other one out. So. No problem. All
And
right.
also remember, guys, like Brady and I said, the questions that they're going to give you on the exam are going to be able to be done in your head or on the notes function. So a lot of these more extensive questions that have really weird family trees, you might not see that on the exam. So understand the concept, do the practice questions, but at the end of the day, they're going to give you questions that you can do in your head.
Like this one. So it'll be like this. So look, family history shows that the brother has a daughter with cystic fibrosis. The brother has a daughter. So what's the rule here? Brother with a daughter. That's the 1/2 rule, right? You're asking about the uncle. Okay. Husband has a brother. So that's the rate to the husband is the 1/2 rule. Also, the wife has a sister with cystic fibrosis, which means that's the 2/3 rule, right? For sister has cystic fibrosis, 2/3 risk that the wife will have the disease. So that's 2/3. So, you know, it's autosomal recessive, 1/2, mom's 2/3, dad's 1/2, Mendelian frequencies 1/4. So you could do this in your head if you just know the rules. You don't have to draw it out. Okay, this is how they're going to put it for you on the exam. The key point is you don't want to have to draw these out. You want to identify that we're using the rules here, right? 1/2, 2/3. Okay, so that's how they'll do it for you guys. This was the one. Let's try this one. Okay, we'll do it together. She has a niece who is a known carrier for the mutation. All right, so we can't use the rule because we're looking at a carrier. This is, again, probably a little bit out of the scope, but let's just work it through. Now, the husband is from a population where cystic fibrosis is 1 in 3,600. Okay, so when we see this incidence, we're not going to forget to multiply by 2. Okay, that's the thing to remember. So if we work this out, do it like this. She has a niece who has known carrier. Okay, let's actually draw it like this. Give me a second and I'll. She has a niece who's a known carrier for the mutation. So we know that. So we're questioning this woman. She has a niece that's a known carrier for the mutation. Now, we don't know whether she got the mutation from mom or from dad, all right? So there's a 1/2 chance that she got it from mom, and there's a 1/2 chance she got it from dad. So we're just gonna go this route, and we're curious about this person. We know that they share 1/2 of their DNA. So that's why this person, I'm sorry, actually, this person, this child is a 1 because she is a carrier, right? We know, we're asking about the carrier frequency. So then you know that there's a 1/2 chance she got the mutation from mom, and then you know that these two share 1/2 of their DNA from their parents. So then you would multiply 1/2 times 1/2. So again, you can't use this rule here, but that's why this person had a 1/4 chance. Okay, so that's where we got this 1/4 from. Okay, you just have to work backwards. Again, they're not going to give you these because y'all don't have whiteboards, but I just felt bad. All right, and then to figure out the 1/30, this is going to be important. 1/3600. So if we say that's our incidence rate, if we know that's our incidence rate, then we take the square root. So 1/60, but we want the carrier rate, so we have to always multiply this by 2. So that means 2/60 is 1/30. Okay, they will put answers that are incorrect where you forget to multiply by 2. Okay, so never forget when we're looking at this carrier chance, we have to always multiply by 2 to get the heterozygotes. Okay, so again, this is probably a little bit out of the scope of what y'all are going to get, but if you understand this, you'll be good to go. All right, I pulled this out of I think a first aid question book, so try this one. So what we're curious about are these two. So you could kind of work this out as autosomal recessive, right? Because these are each different genes, and you could treat them like that. And you want to know what are the chances that this child gets both the DR3 and the DR4. So if you assume it, like I said, like an autosomal recessive, because these are each individual alleles, right? There's a 1/2 chance, okay, DR4 and DR3. There is a 1/2 chance that this male got this DR4. There's a 1/2 chance it got a DR8, 1/2 chance you got a DR4. Same thing over here. This lady, 1/2 chance she got a DR3, 1/2 chance she got a DR7. Then we know for this child to have the disease, right? For disease, 1/4, right? Mendelian frequency for autosomal recessive. So we'd have to multiply dad's frequency, 1/2 times mom's frequency, times the Mendelian frequency of the disease, and you get 1/4. And that's how we got 1/16, okay? All right, try this one. Make sure you recognize we're looking for the homozygotes, not heterozygotes. Okay, so the of homozygotes in the allele. Oh, okay, I'm sorry. So homozygote, not homozygotes, normal, but homozygotes. So you're asking how many people will actually have that in the population. So 1 in 400 squared is 1 over 1 in 160,000. Okay. So if the, right, so if incidence is 1 over 400, then you could say that you would, so whereas Q equals square root of I, you can also say I equals Q squared. So 1 over 400 squared would give you the incidence of homozygotes for the diseased allele, right? Which would be 1 in 160,000. Thank you for that. All right, so if you're looking for a carrier and you know Q is 400, right? You would use 2Q to figure that out. So if you have a carrier, then you would just multiply by 2 like we have, and you know the heterozygotes or the carriers would be 1 in 200. Sorry, it's been like a year since we've actually had to do any of these. I apologize. All right, so if we look at the lac operon now, we could look at this. This is a difficult question, but it'll help us walk through how it works. So what you want to find here is what's going wrong. So in the presence of glucose, should this be coded? No, right? So it's a twofold system. One, if there is glucose present, there's no point in metabolizing lactose, right? Because we have glucose. Glucose is primary, it takes precedence, it's easier to metabolize. So just use glucose. We also don't want to start making these enzymes if you don't have lactose present. So it's a twofold system. So I'll show you the answer and then we'll walk through it. So what this means in the presence of glucose, it's supposed to be able to bind to this receptor. And if it does that, it'll prevent binding to allow transcription. Now we'll walk through it real quick and I'll explain it further. All right, so this lac, as you can see here, this lac repressor is the it's like a stop sign, right? So you need twofold systems. You need the promoter to be there to transcribe, but you also can't have a stop sign at the lac operon. Okay, so if no lactose is there, we're going to say we put the stop on the lac operon. That'll cause repression. There's no point in metabolizing anything if there's no lactose. But also now in the presence of lactose, you make allolactose that can bind to this repressor. So then therefore lactose, you can have these enzymes transcribed so that you can metabolize lactose. Okay, now in the presence of no glucose, this CAMP will have a binding site, right? And you can see that if no glucose is present, CAMP is produced, and that allows binding. Okay, but what actually happened before in the question is that glucose was present. So then why didn't this bind? Well, the answer was there was a mutation at this CAMP binding site, which means even though glucose was present, you couldn't, this bound regardless, okay? So that was the problem. And that's why even in the presence of glucose, you were making all of these enzymes, okay? So, right, so in the presence of glucose, which was what the press in the vignette says, glucose can't suppress the transcription, so there's mutation in the CRP CAMP binding site. Okay, so this was supposed to be bound here. Yeah.
Sorry, I have a question. Isn't it like when glucose is present and it's high, CAMP isn't made and CAMP doesn't bind to CRP. So it's only when glucose is low does CAMP increase, then CAMP can bind to CRP and that binds to the promoter. So then I'm confused why you're saying when glucose is present, there's a whole binding of CRP.
Because that's the question is, why is this happening? Because there's a mutation in this site. So if glucose is supposed to be present, the CAMP is not around to bind the CRP. So the CRP can't be activated. But there was a mutation that caused, in the question, there was a mutation in the CAMP receptor that caused it to be tonically activated. Okay, so that's why even in the presence where the CAMP was supposed to inactivate this, there was a mutation at this binding site, which allows it to bind anyway. Okay.
Okay, that makes a lot more sense.
Yeah, and yes, because the glucose you have to remember that it's a promoter. So when there's no glucose present, that's why it binds, because it promotes the transcription of the enzymes. And again, this is a difficult question. I pulled it out one of the step prep books. But yeah, so if there is a mutation here, even though CAMP is not present, right? Because glucose is around. Even though it's not present, the CRP was activated. Because of the mutation, and that allowed it, even in the presence of glucose, to bind to the promoter. If you have the promoter bound, and of course lactose is there, so lactose is going to bind our stop sign, remember, at the operon. So since lactose is there, it's going to bind this so that this operon is free. This, you know, if there was no lactose present, this stop sign would bind there. But since lactose is there, it's going to hold it off. So then you go ahead, right? So that's the mutation involved with that, right? So that's what I was saying. If there was lactose there, this is what's supposed to happen. There is lactose, it's going to remove the stop sign. But with glucose there, it's supposed to inactivate the CRP, but it couldn't because of mutation. That's why in the presence of in the presence of glucose, you're still making this these enzymes. So when in doubt, just remember this little table here. You should be able to answer the questions. That question I did is probably as hard as it gets in regards to this, but just remember these. The only time you're ever going to transcribe these enzymes is in the presence of lactose and if glucose is not there. Make that make sense to you. You don't want to transcribe anything if there's no lactose. Also, you don't want to bother breaking down lactose if there's glucose already there. Okay, if those two sentences make sense, then you could work this out. Never make it in the presence of glucose, never make it if lactose isn't there, okay? All right, try this one. And I apologize for the pedigrees. If y'all want to stay back after and y'all have specific questions, we can go through them again. I think I was getting tripped up on the carrier versus diseased frequencies. So we can look at that if y'all are still confused after. All right, we want expression, right? So euchromatin, okay? Remember that it has to be this Mic-Max heterodimer. Why is it hetero? Because they're opposites. Mac-Max, Mic-Mic is homodimer. So in order to initiate transcription, you need this Mic-Max dimer. So, right, so if Max is present as a homodimer, you're not going to get transcription. And that, so you get heterochromatin. If you get this Mic-Max heterodimer, you will get transcription. What's interesting is Mic is sometimes responsible for some tumor formations. That should make sense to you because if you get overexpression of this Mic, you're going to get overexpression of some cell population. And by definition, that's cancer, right? All right, we're going to get on to autonomics. And man, it's so important. I know it's confusing, but you got to know it now because every term you talk about it, you get pretty decent at it after a while, but it does take a little bit of learning. So y'all will probably get into the histology. I don't know if y'all do it in FDM2, but these alpha motor neurons kind of look like this. Not that that's a great drawing, but they're very classic. If y'all have come across it, just make a mental note what they look like. So they're only formed in the motor area. And where's the motor area? Motor's always in the ventral horn. So if they could show you a close-up histology of these little teardrop cells, little nuclei over here, those are alpha motor neurons. So remember, dorsal horn is going to be your sensory system. Ventral horn is going to be your motor system. The lateral horn is where your autonomics come from, but they traverse through the other ports with the dorsal and ventral horn, depending on the situation. But yes, ventral horn is going to be your motor system, okay? Yes, got it. Okay, you can see that here. So white matter is always, well, so it switches in the brain, but in the spinal column, white matter is always on the outside, gray matter is inside. In the brain, it's flipped. Gray is on the outside, white's on the inside. White matter is white like this because they're neurons. So all of the cells are in the gray matter. The fibers are in the white matter, and they say white or they come up white because they don't stain well because of the sheath. the sheath outside of the myelin is like a lipid, so it doesn't stain very well. So in this white matter, it's all tracks, right? It's all fibers communicating. This gray matter in this butterfly is where the cells are. So just keep that in mind. And all of the cells are going to traverse through here, and then they take tracks out where they go, right? So just remember, it kind of looks like an upside down butterfly. That's important to know because these ventral horns, they should show you this cut like this, where gray matter's in the back. I'm sorry, the dorsal horns in the back and the ventral horns in the front, but they could switch it. Just remember the big part of the wings of the butterfly correlate to the motor side, the ventral side. Okay. All right, try this one. All right, so the lateral component is where you're going to see the gap junctions. That should make sense. These gap junctions are just little holes, right? So that ions can go through and you can communicate cell to cell, side by side. Okay, so, and it's important to know what goes with what. Well, first off, let's just define, because sometimes it's difficult looking at these. The lateral ones are always going to travel parallel. So if this is one cell, and this is another cell, okay? The lateral components always go parallel. You're gonna also have this, it's kind of like these junctions down here that come across. So the ones that fall on the other side are the transverse side, right? Right down here. So if you're looking, when you look at this, the part that separates the cells, if you're looking for the lateral component, you want to find the fibers that go the same way. So if you're looking here, like all of these fibers here are traveling parallel to this. So these two cells right here and right here, this is the lateral side, okay? And the cells down here are the basal side, right? Okay, so you try to find them, the ones that are, whenever they're running parallel to each other like this, that's where the gap junctions will be. That's where the lateral. Okay, and you can see here, the transverse component, again, you find the little part below it, and that will be where you see the fasciculate adherens and the maculate adherens. Which one travels on both? Okay, yeah, maculate adherens are the ones that travel on both, the transverse and lateral component. So just remember the lateral side is the one they're stacked up like this. The ones that lay long ways are going to be that. So if you can identify those two sides, that's all you really need to know. All right. All right, before we look at this, let's just make sure you have that straight. Right, so you find the parallel lines, right? So right here, this right here has to be lateral because they're running parallel. So you know what travels there. And then the transverse is the one that's between them on the bottom side. Okay, so the way I do it is I just try to find the parallel lines and then I know. All right. Right, autonomic nervous system, very primitive aspect of the brain, comes from the brainstem. Brainstem has a lot of important components, not only your cranial nerves, but you have things like the respiratory center, your arousal center, and things like that. So very primitive aspect of the brain, whereas as you kind of spawn outward, you get into the higher order thinking. So the autonomic nervous system was here when we were amoebas and, you know, growing like fungi. It's all important, so it was a very primitive aspect. So it comes from the brainstem. Y'all will get into this a lot more going forward, but I put that in there. Elastic connective tissue, right? So silver stain isn't used for that. The ones that have these weird people's names, sometimes they just call it elastic stain, but these people's names are the one that you can stain elastic tissue for. What is silver stain for? Reticular fibers, right? Those short, thin, and branching fibers. All right, so you can see this, these people's names, those are the elastic stain you can use. You see these elastic fibers running here. All right, what about this one? Note the positioning of the nuclei kind of pushed to the side, right? But this is going to be considered multilocular cells. Signet ring cells do look a little similar with the nuclei pushed to the side, but these are multilocular. You can see the multiple vacuoles in there as well. And this is what I was saying in regards to adipocytes. You can see that the fat kind of pushes the cells to the nucleus. So obviously they'll stain differently. You can see these big fat cells, they don't stain in H&E. Those will be, you'd have to use PAS stain for those. And then you can see this multilocular or brown fat. This is what babies, it helps to keep you warm. It bypasses the electron transport chain so that you can actually just burn heat instead of making ATP, helps keep babies warm. Also, that's what bears use for hibernation. They have an abundance of brown fat. So just a way, opposed to making additional ATP, you're just burning fat off and keeping yourself warm. Okay. So in regards to cross-linking lysine, remember, when you talk about collagen to collagen, the triple helix, it's usually a 3-part system, 2 parts, well, either a proline and a lysine, and then the third spot is always glycine. But when we're talking about cross-linking, remember, use lysyl oxidase. I believe copper is the cofactor for that. You can see that here. Yeah, copper is what you need to do that. So this is different. Don't get that confused when you're making the cross-linkings of collagen, because you need vitamin C for that. And that's where you use glycine proline, I believe hydroxyproline as well. But when you start making these elastin chains, you want to use lysine and lysyl oxidase, okay? Straightforward, anytime you see gum bleeding, scurvy, right? They actually diagnosed this in pirates because they didn't have vitamin C, they didn't have fruit. So they had an abundance of this as well. So of course, this is collagen formation. And you can see that here. So deficiency in the cofactor vitamin C, you can't properly make collagen. They get this, these bruising, gingival hyperplasia or bleeding of the gums as well. Yeah. Right, like we said, these hydrogen bonds will help to stabilize the triple helix, glycine, proline, hydroxyproline. Again, you need vitamin C for that stabilization. And then once you start making elastin, that's where you use lysine and lysyl oxidase with the copper. All right, so this is very classic. If y'all remember a few years back, this guy from Baylor got drafted into the NBA. You look at the guy and you could just tell the guy had Marfan's. He had like subluxation of the lens, but somehow he got all the way through college and they never diagnosed him. He was about to make sign a multi-million-dollar contract. And the NBA, the doctors in the NBA, they said, absolutely not. You have Marfan's, you're like 7 feet tall. And like it looked pretty classic. So he lost out on a couple, multi-million-dollar contract. But the point I want to bring up is the reason they don't let you play sports when you have Marfan's is because you have a predominance for aortic aneurysms, and that's because of the tunica media in the middle of your aorta that goes under high pressure. It has weakness in that tunica media, so you're prone to aneurysms, aortic aneurysms. Okay, so you're not supposed to play sports, but this is a person with Marfan's, and that's a problem with the fibrillin component. Okay, and you can see that here, very tall, very characteristic. But you can see here, no, you're not allowed to play sports because of this, right? It could be a thoracic aortic aneurysm, it could be abdominal. but it's because of this high pressure system coming out of the heart that they're prone to ruptures there. Right, okay. So we touched on this a little bit last time, but since y'all got into it more now, I do like first aid when I look at these, going through these different graphs, but we'll break it down. So we want to decrease potency. So whenever you see the word potency, you want to think about Km, right? Remember, Km is inversely proportional to potency. So a high Km equals a low potency. And we also know that Km correlates to the x-axis. All right. So doesn't want to compromise drug efficacy. We know efficacy correlates to Vmax, right? And Vmax is on the y-axis. Okay, so we want to decrease potency. So if you have a Km here, if your Km's here, right, you have a high Km, I'm sorry, this is a low Km compared to right here. So low Km here at this point means a high potency. This is like 1 milligram of the drug. All right, so if we decrease our Km along here, now if we, I'm sorry, we're increasing Km, right? Because we're getting a larger number on the x-axis. That means we're decreasing our potency. So maybe 10 milligrams of the drug. It's decreased potency, okay? So low Km equals increased potency. So we want to decrease the potency. So we're gonna go this way on the x-axis, but we don't wanna compromise our Vmax. So we're not gonna change our efficacy or our y-axis. So curve B correlates to a decreased potency. So right here, you could definitively say that curve B has a decreased potency than curve A because we changed our Km. We made Km larger, which means we decreased our potency. What about if we compared curve A to curve C? Curve C would have a decreased potency, but it would also have a decreased efficacy too, right? Because we changed the y-axis. What is D? Does anybody know?
An antagonist.
Antagonist. And I want to bring this up because sometimes you would think, well, shouldn't an antagonist go this way, right? A curve like this. This is not an antagonist. This is an inverse agonist.
An inverse.
Yeah, this is an inverse agonist. The point of an antagonist is you just don't allow any positive impulse, right? Nothing positive happens. You're not actually getting a negative effect. You're just stopping the positive effect, right? So if A would bring up your heart rate, okay, an antagonist would simply prevent the increase in your heart rate. It wouldn't make your heart rate go down, okay? That's an inverse agonist. It would simply prevent the increase of your heart rate. So if you ever see a straight line like that, it's just an antagonist. It's antagonizing the drug that you were of interest, right? All right, so this is a good slide. It kind of explains them both. Potency x-axis Km, efficacy y-axis Vmax, right? What is D? D is an antagonist. And as you can see here, so if a full agonist would increase your heart rate, an inverse agonist would decrease your heart rate. An antagonist would just keep it the same, okay? All right, try this one. All right. So if it has a higher affinity, it has a higher potency, right? So higher affinity, meaning higher potency. So remember, Km is inversely proportional. So a high potency equals a low Km. Okay. So Km for the reaction of A is lower than B because A has a higher affinity or a higher potency. Okay, so just keep in mind that they're inversely proportional, the Km and the potency. There you go. All right. Plus an irreversible antagonist. Okay, so curve C. So the way irreversible antagonist works is that it's going to decrease your Vmax. It's going to decrease your efficacy. Now, I wanted to put irreversible antagonist because this also looks like a different curve. Y'all will look at, y'all will be able to see. So it also looks at like a non-competitive reversible inhibitor. Okay, because if it's non-competitive, you're going to change your Vmax. If it is competitive, you're going to change your Km. Okay, and that I think I have, yeah, this is from first aid. So this kind of explains it, right? Competitive antagonists are always going to compete for the same site. So it's going to deal with the ability to bind, the potency of the drug. So competitive antagonists are always going to deal with Km. Non-competitive antagonists, they bind at a different site. So regardless of the concentration of the drug you have, it doesn't matter because it's going to bind independently to another site. So therefore, you're decreasing the efficacy of the drug. You're decreasing your Vmax, okay? So just keep in mind that competitive deals with Km, non-competitive deals with Vmax, or the y-axis or Vmax, right? Okay, so if you keep those in mind, you can keep them straight. I wonder if I put the line, let's see. Okay, just let me show you something real quick too, because sometimes they do the logs of these. They'll show you like this. And they'll give you a drug like this. And they'll say which one is competitive and which one's non-competitive. So the one that, there's a trick, the one that competes with it across the y-axis is always competitive. So if blue is our normal line, since the red on this graph is competing right here at that point, it's competing across the y-axis, you know that's a competitive inhibitor. The green one, since it's not competing across the y-axis, there is your non. That's just a little trick that first aid uses. Okay, so you try to look at this point. Since the blue and the red are crossing right at that 0 point on the y-axis, that means it's competitive. Okay, that's just a little trick. All right. All right, let's try this. And I have a trick of way of doing this too, because I don't like that silly graph. All right. Yeah, I'll give you a second to look at it. All right. So the way I like to think about this, aspirin is an acid, right? And they'll tell you in the question that you're dealing with an acid. Now, acids are always going to be absorbed in the stomach. Now, you can remember where the H ion is, if it's attached, if it's not attached, what's charged. That's fine if you want to go through it. But the quick way of doing this is acids are always going to be absorbed in the stomach. All right. So if you use your equation and you get, there's a difference of 1 here. So let me just pull this up so it'll make a little bit more sense. This, right? So people get bogged down with the unprotonated and protonated stuff. But if I told you it's an acid in the stomach, you have to be in this range. Why? Because the acid is going to be absorbed in the stomach. Okay. So it's very simple. If you have an acid in the stomach and the differential between the pH and pKa is 1, then it's going to be 90. If the difference is 2, it's going to be 99. Now, what if they told you that what is the aspirin being absorbed in the duodenum or the small intestine? Well, we know bases are absorbed there. So if you have an acid in the small intestine, you're going to be on the lower end. Okay, so if you want to work it out with the protonated, unprotonated, it all works out the same. I'm just saying, if you know, if they're going to tell you the drug's an acid or a base, and if they're going to tell you if it's in the stomach or the intestine, so definitively you could say whether it's on the higher end of being absorbed or the lower end. That's kind of how I do it. It's a faster way of doing it. But if you see here, right, we know so we're on the higher end, right? Because it's an acid in an acidic environment, okay? So the differential is 1, so that means it would have to be 90. If the differential was 2, it'd be 99, 3, 99.9. If they changed this around and said, you know, it was an acid in the duodenum, then you'd go to the other side, right? You would go to the side of 10%, 1%, right? All right, and then, so if you wanted to work it out, acids, right, again, in the stomach, bases in the intestine, so you know if it's gonna be in the area where it should be absorbed, they match up, then it'll be in the 90 range, okay? So that's just a quick way of doing it, but you still need to remember these numbers, like 1, 2 versus 3. The way people do it is 1 has 1 9, 2 has 2 9s, 3 has 3 9s, okay? All right, try this one. Oh, this one's tricky. All right, so we know that the steady state is 4 half-lives. All right, so we'll work this out. How many half-lives has it been? All right, so the half-life is 2 hours. All right, so how many half-lives has it been? 2, right? Okay, so at what? Oh, you're right. Okay, so 2 is 75, 3 is
87.5.
thank you, 87.5. All right, good. All right, so we know after 2 half-lives, right, you are at 6, right? And 6 is 75% of your total. So if 75% is 6, then at 4 half-lives, it has to be 8, right? So 6 divided by 0.75 equals 8. So you're 2/3 of the way there. So if 6 is, I'm sorry, you are, yeah, sorry, 3/4 of the way there. So if 6 is 3/4, then you just add 2 and you get 8. All right. So you're given 400. So at 1 half-life, you would be down to 200. All right, and we're saying first 120 minutes. Right, so we're saying that we could definitively say, since we went down half, we could say that the half-life of the drug is 2 hours, right? So we went from 400 to 200 in 1 half-life. So we could say that 6 hours is 3 half-lives, right? Because 2 hours. So if 1 half-life, you went down to 200, second half-life, you'd go down to 100, third half-life, you would go down to 50, okay? So the key in these is to figure out what the half-life is, and then from there, you can say, Well, how long has it been? 6 hours, 3 half-lives, so the answer should be 50. Okay, good. Right, the big thing to remember is steady state, even though it comes out to like 93%, they consider that 4 half-lives is what's considered steady state. Okay, so this works both ways. If you do the infusion of the drug, it takes 4 half-lives to get to steady state. If you were to get rid of the drug, eliminate the drug out of the system, it would take 4 half-lives to go away. Okay, so it works both ways. Now, it is important to understand the difference between first order and zero order elimination. First order is a constant percentage of the drug. So you can almost think of it as a better way of doing things, right? If you can eliminate the drug 50% of it at a time. Okay, so regardless of how much drug, you could take a whole lot of the drug, regardless, 50% is going to be eliminated at a time. So it's a percentage basis. It's eliminated on a percentage basis. Now, it may not be 50%, it may be 20% of the drug, but if we're doing half-lives, then you would definitively say that would be 50%. But it may be 20% an hour of the drug. The point is you work with percentages. Now, the problem with zero order elimination is you get a constant dose or a constant, milligrams eliminated per hour. So for these drugs, as much as you take, you're only going to get rid of a constant dose of it an hour. This is why things like phenytoin, ethanol, and aspirin, they use the mnemonic P, are very easy to overdose on, because if you drank a ton of alcohol and you got rid of 50% an hour, that would be good, right? Theoretically, opposed to saying you're drinking 8 beers an hour and you could only metabolize 1 beer an hour, right? So like a constant dosage. So that's how they work out differently. You can see here, this is being a constant percentage here. You can see the slope of this curve. And right here, this would be a constant dosing rate, okay? So that's how they do those, that's how those work out differently. So again, that's why zero order elimination, opposed to being a percentage and it have to be a certain dosage or a constant amount they use here, that's why those are easy to overdose on. Okay, try this one. So they gave y'all a chart with these, or a table. There was like 5 or 6 equations. You need to know those by heart, okay? Generally, these equations are just going to, you'll only need one equation to solve it, such as this one. Sometimes you'll need to find out one variable with one equation and fit it into the second equation, okay? So that's as far as they'll go. But for the most part, because you don't have paper, they make these pretty straightforward. So we want to know the loading dose. So if you remember the loading dose equation here, volume of distribution times the target concentration. Target concentration is the same thing as saying steady state concentration, okay, over bioavailability. Since it's an IV medication, the bioavailability is 1. They tend to use IV meds because the bioavailability is always going to be 1. If it's an oral medication, the bioavailability changes, right? It decreases because you only are able to absorb a certain amount. That depends on the concentration or the components of the actual drug. But for the most part, if you remember, IV bioavailability is going to be 1. If they give you some sort of oral medication, they'd have to give you the bioavailability in the question, so you would know it. So you can just work this out, fill in these equations. Sometimes they'll try to trip you up and give you clearance. Clearance isn't even needed for this, so they'll give you extra information. That's why it's difficult to do these, because they will throw extra stuff in there. So you need to know which equation to use for these. All right. This is tough. It may be a little out of scope. I'll give you a hint. Think about the fact that the patient has chronic renal failure. Okay, what's that going to happen? What component does that affect? Think about the equations.
It affects clearance.
It does, yes, exactly, right? So think about the equations and what equations are used here that would affect clearance. Right, so if we look at these, the loading dose doesn't change. The component of loading dose tends to be volume of distribution. So if the drug's highly lipophilic, it tends to spread out a lot, right? Because things that are lipophilic aren't charged. So if it's not charged, it could jump through membranes, it tends to store up in fat. So when you think about a loading dose, you have to think about how much of this is actually going to stay in the plasma and how much is going to go out to the body, because that's going to affect, if it's anesthesia, it affects how fast the patient can wake up. Right? If it's all stored in the adipose, right, it's harder for the patient to wake up. They have to modify it based on your weight. Now, when you're talking about maintenance dose, you're going to talk about clearance. You're going to talk about how fast is this drug going to get out of the circulation, out of the system, and is any of it going to get backed up? So if a person's in chronic renal failure, you're worried about how well they can clear the drug. The vast majority of drugs have to be cleared through the kidneys. So if that's the case, a person with chronic renal disease, you're going to have to lower the maintenance dose. Again, you're not worried about loading dose, volume of distribution. It doesn't really matter for this. We're worried about how much of the drug is going to remain in system when we would expect for the patient to pee it out, right? So this is just more of like a practical application of how this is actually used clinically.
We're using the same loading dose because it's just like we're comparing the two.
Yeah, you use the same loading dose because we're not worried about this patient's whether, how well the drug's going to be distributed in the patient's body. We're worried about the fact that he's not going to be able to clear it out of his kidneys because his kidneys don't work well. Okay, so if you look at this, if we look at the loading dose, we're only worried about clearance. That's the only problem at this point. So loading dose equation doesn't change. When we look at clearance, that's what we're talking about. You can't really eliminate the drug, so you have to change the concentration. Okay, so this is very important. You want to know these equations. I told you all the trick I use for this. Acid in the stomach gets absorbed, so you kind of don't need to know this one too much, but you definitely need to be able to recite these. Okay, you can use 0.7 for T1/2 if you want, but yeah, it's going to be important. Like I said, the worst they'll do is like give you one like equation like this, so you have to figure out volume of distribution to plug it in here or something. They could do two equations, but for the most part, it'll just be plug and play. All right.
Sorry, Brady, one question on the formulas.
For sure.
When you calculate dosing load, you divide it by the bioavailability, and if you use the dosing load in the maintenance dose, do you divide it by the bioavailability or no, or just by once?
No, so it would just be once, right? Like, yeah, no. So yeah, no, every equation's independent. So the bioavailability is not going to change. So it should correlate the same. Yeah, you wouldn't have to do it again for that.
Okay, perfect. Thank you.
All right, let's talk about autonomics. So you need to keep these words synonymous, right? So let's talk about the sympathetic system, right? Sympathetic is your fight or flight. Sympathetic is running away from a bear. If you think about that, things that need to happen when you're running away from a bear, your heart rate's going to go up. You're going to start sweating. Your pupils are going to dilate, right? You're kind of on edge. That's the sympathetic system. Whereas the parasympathetic system is your rest and digest. That's when your eyes kind of, you get meiosis, right? Your eyes get more constricted. You're able to digest. You go to the restroom, stuff like that. So they're very polar opposite of each other, and those work together to help coordinate. Generally, you have a low level of both going on. It's like a seesaw system, right? So you have low level of both, but if there's something that initiates it, like you just ate a meal, parasympathetics will kind of take over in the gut. If you're, like I said, running away from a bear, your CNS system will kind of light up, and you kind of, your sympathetic system will take over. So this is the mnemonic they use for point and shoot. So the process of erection and ejaculation is a twofold system. You have to use the parasympathetic system and the sympathetic system. So I'm sure you have heard this mnemonic now. Point is for erection, parasympathetic, and sympathetic is ejaculation. Now, let's take these two out of the equation. Let's say you didn't know, like this is what I was talking about, like the art of doing stuff like this. You weren't exactly sure, but you were saying, okay, so sympathetic is fight or flight, right? Parasympathetic is rest and digest. If I'm resting and digesting, my heart will probably slow down, right? I'm not running away from a bear. So that's parasympathetic. GI wall contraction, that has to do with digestion, all right? So that will help to, that's more of parasympathetic. And meiosis means your eyes are constricting. And so that's more of a parasympathetic process. So just by elimination, you can get rid of the parasympathetic stuff, and then it comes down to, which one of these correlates to what. Okay, so that's kind of using the test. Even if you don't know, sometimes it's easier to rule out 4 answers than it is to rule in the right answer. And that's just part of the system, right? All right. And this is how it breaks down. So the somatic system is under your control. The autonomic system is things that happen in the background, right? So that's how that's going to work. Remember, somatic versus visceral. Somatic is more of your being able to feel on your skin, things like that. It's very pinpoint, whereas visceral means organ. So that's organ pain or organ sensation. Typically, that's more of a diffuse pain, a dull pain. Okay, let's take a little break and then we'll get into it in some more detail. Let's, I don't know if y'all had Dr. Schatz, but this is one of her slides, so we all love her. Anyway, we'll take a 5-minute break. All right, I know we're going fast. I apologize if we don't go fast. We're gonna be here for like 6 hours. So that's why we record it. Y'all are welcome to go back and look at it, but there's really no other way around it. Nobody wants to be here for 6 or 7 hours. So we kind of try to get as much done as we can. But as always, these are recorded, so y'all can go back and watch them. All right, so again, the autonomic system is, it's beyond our control. It's not a voluntary thing. It's all involuntary. Everything happens in the background. So when you talk about craniosacral, right, up at top in the brainstem and in the sacrum, you're talking about parasympathetic. They're craniosacral. Thoracolumbar, that's where your sympathetic chain is. That's where the sympathetics come from. So in general, they all have the same process. They have a preganglionic neuron, whereas parasympathetic, they have a long preganglionic neuron and a short postganglionic. It's just a 2-wire system, right? The preganglionic goes, synapses, and goes to the postganglionic, okay? For whatever reason, they like testing on the fact that which one has the long preganglionic, which one has the long or short postganglionic. So parasympathetic has a long preganglionic, a short postganglionic. Sometimes the postganglionic fibers are just like in the actual organ, and the preganglionic will go all the way to the organ. Whereas the sympathetic system has a short preganglionic neuron and a long postganglionic neuron, okay? So you can see here that this junction between the pre and post is the autonomic ganglia, okay? That's what that's called. You use nicotinic acetylcholine receptors at the autonomic ganglia, okay? So that's always going to be what you use there. These nicotinic acetylcholine receptors. Now, the parasympathetic system at the end terminal, where the postganglionic meets the actual cell, you're actually going to use acetylcholine as well. So parasympathetics are synonymous with muscarinic receptors. The autonomic component of parasympathetics is muscarinic, okay? Now, there's, again, note the difference. The nicotinic receptors at the autonomic ganglia use acetylcholine. The muscarinic receptors, these parasympathetic N-terminal fibers or N-terminal receptors, also use acetylcholine, okay? So if you're talking about parasympathetics, you're talking about muscarinics. These words are used synonymously. Now, when you look at the sympathetic system, you're going to be using norepinephrine, primarily norepinephrine at these terminals. And touched on the alpha and beta terminals. Sometimes in the kidneys like to use dopamine as well. That's kind of beyond what y'all are doing. We talk about that later when we do pharmacology. So just remember, the muscarinics is parasympathetics. The adrenergics are sympathetics. So think adrenergics as adrenaline, right? That's norepinephrine. So if you're running from a bear, you want adrenaline. You want these adrenergic receptors, okay? Alphas and betas are adrenergic. Okay, two very strange, not strange, but exceptions you need to know. Even though the sweat fibers are technically sympathetic, right? You're running from a bear, you need to sweat to cool off your body, right? Even though those are sympathetic fibers, they have a muscarinic receptor. We don't make the rules, it seems backwards, but that's just how it is. Now, y'all don't need to worry about this too much now, but later on, y'all are going to talk about how to differentiate a sympathetic overdose versus an anti-muscarinic drug. And the way you do that is through checking the sweat glands, because, but just know that this is a weird exception. The other weird exception that you need to know now is that in the adrenal medulla makes catecholamines. If you remember when we talk about pheochromocytoma, those cells, those chromaffin cells, the adrenal medulla does not, there is no postganglionic fiber. This preganglionic fiber goes to acetylcholine and it synapses on the chromaffin cells. So they're released directly into the blood. So there is no postganglionic fiber there. But these chromaffin cells will release norepinephrine and even epinephrine into the blood directly, okay? Now, as always, somatic fibers, your voluntary motor fibers, again, use acetylcholine, but these are the neuromuscular junction, those fibers, okay? So you can see the different fibers that you have there. Neuromuscular are gonna be the somatic fibers. These autonomic ganglia are going to have nicotinic fibers, and then parasympathetic or muscarinic. You should say that in your head when you're thinking about parasympathetic is muscarinic, sympathetic is adrenergic, okay? Use them synonymously. You could also say parasympathetic is cholinergic, right? Because we use they use that sometimes. Acetylcholine is the receptor or the modulator right there, right? Acetylcholine. So they use that sometimes as parasympathetic. They'll say cholinergic. Same thing. Cholinergic, parasympathetic, muscarinic, all the same thing. Okay. Again, they like to test on this. Sympathetic has short preganglionic, long post. Parasympathetic, long pre, short post. Right? You can see here how they work. The cholinergic, again, cholinergic, parasympathetic, muscarinic. Right? The acetylcholine is released. It binds to these postsynaptic membrane, the neuron over here, to initiate a response. Whereas noradrenergic or adrenergic or sympathetic are going to bind here. Again, y'all, pretty sure y'all learned the pathway. Tyrosine is the precursor to dopamine, which is precursor to norepinephrine and epinephrine. So they bind postsynaptically to the adrenergic receptors. Okay, fight or flight. This is so important. It's probably the most important slide or page in first aid. You just gotta know it. For right now, y'all could probably get away with knowing the first couple, but eventually you have to know everything. This is because it's so important. It's such a common drug target to be able to help to modulate the heart rate and stuff like that. If you could help to block some of these receptors or whatnot, or upregulate them. So this is what they use. Y'all have learned these G proteins by now, the GQ, the GS, the GI. This is a very easy way of remembering what receptor works through what G protein class. So it's KISS, KICK. Alpha 1 is Q, alpha 2 is always inhibitory. Both the betas we don't talk about beta 3, but both the betas we talk about are through the GS pathway. And then cholinergic or muscarinic or parasympathetic down here is KICK. M1's work through Q, M3's Q, and M2's I. So yeah, so you really need to learn these. So some tricks I like, you have one heart and two lungs. Beta 1 primarily works on the heart. That's a big drug target for the heart. Two lungs, beta 2 is common. It's used in the lungs, right? So if you talk about bronchodilation and stuff like that, albuterol is a beta 2 agonist. Beta 2 because the lungs, it helps to bronchodilate, okay? Dobutamine, I don't know if y'all talked about these drugs. Dobutamine is a drug that they use in cardiac failure. It's a big time beta 1 agonist, okay? So, and then y'all will get into this a lot more later, but when you talk about vasodilation, you talk about beta 2. When you talk about vasoconstriction, you talk about alpha 1. Seems kind of counterintuitive. If you're running from a bear, why do you need vasodilation? Well, the thing is, at low levels in your body of, say, epinephrine, you have beta 2, right? So you have low levels of epinephrine, so you're just kind of vasodilated. In an instance where you have to run away from a bear, you get much higher elevations of epinephrine, so you get a vasoconstrictive effect. Okay, again, that's something that comes up later, but just remember, it may seem a little counterintuitive, but beta 2 deals with vasodilation. Okay, so some of the drugs y'all talked about, these cholinergic agonists. To be honest, y'all do this so much in term 4 that they really don't test these drugs that much. I think we can all say that. It was our term, the term below us as well. They really get into these. So y'all just need a general understanding of these and like first line drugs for certain things. But other than that, it comes up a lot more later. Okay, so adrenergic drugs. So we're stimulating the sympathetic system here that you can use, again, things such as dobutamine. Remember, beta 1, 1 heart. So it'll help to make the heart pump harder. Beta 2, 2 lungs. Albuterol, help to bronchodilate if someone has an asthma attack. So things like that. Another good trick here, A through M for beta blockers are selective. That means they will select beta 1 higher than beta 2, right? So you can give those. So it's things such as atenolol, metoprolol, they have the olol behind them. These are selective for beta 1 targets, okay? If it starts with N through Z, such as propranolol, they're non-selective, so it has a similar effect or equal effect on beta 1s to beta 2s, okay? So that's just a quick way of remembering those. All right, try this one. So tell me what is atropine? Or, well, let's just do this. So it's an anti-muscarinic, okay? But what is it used for? The thing they commonly talk about is there's a farmer, you have organophosphate poisoning. Organophosphates help to, they're gonna give you the dumbbells effect. So they're gonna upregulate parasympathetic response, like muscarinic agonists, right? So if you ever have someone that comes in with, they say dumbbells, but it's salivation, diarrhea, things like they're all parasympathetic symptoms, you'd want to give them atropine, which is a muscarinic antagonist. So, and that's classically what they'll give, but they'll give you the situation where a farmer comes in, their eyes are very constricted, they're salivating, they have diarrhea, like all of the rest and digest symptoms, and you'll know they overdosed on some sort of organophosphate, the stuff that they put in the fields, the farmers, to kill the flies and whatnot. So you want to give an anti-muscarinic right away to help block the muscarinic response. Now, this brings up an important point. It is very different when you have, like, if you ever have an overdose, you want to give, and so if you have a muscarinic overdose, you want to give it anti-muscarinic. Like, this is very different from saying, well, if I have a muscarinic or a parasympathetic overdose, why don't I just give some sort of adrenergic to stimulate it, right? So if you have all of these parasympathetic symptoms, why don't I give something that activates the sympathetic system? Because then you're kind of pulling the body in both ways, right? Like you're giving it both a parasympathetic stimulus from whatever you overdosed on, and then if you're trying to treat it with a sympathetic, you're making the body try to choose what's going on, and that's not a good. You don't want to do that. The better way to do it is if you have an overdose on a muscarinic or something that's over stimulating the parasympathetic response, you want to give an anti-muscarinic. You want to try to block that response, okay? So you want to bring yourself back to normal. Just saying, if you have an overdose on parasympathetics, let's give a bunch of sympathetics. Like that's not good for the body, because some parts of the body have more fibers for sympathetics than parasympathetics, and vice versa. So you don't want to do that. If there's any sort of overdose, you want to try to counter that response. Okay, so give, again, a muscarinic, or even if it's an adrenergic overdose, you want to give something, an anti-adrenergic, to block that response. Don't necessarily go the other way, because it makes the body freak out. All right. Okay, so myasthenia gravis, what ends up happening? Well, they'll say this patient comes in and throughout the day she feels muscle weakness. Sometimes they present with ptosis, which is their eyelid can't stay open, right? And the problem is they have these autoantibodies against the acetylcholine presynaptic receptors. So you don't get enough acetylcholine in the cleft. So over time, if you keep using it, you're going to use up all of the acetylcholine and all of the receptors that are available, because these autoantibodies will bind to those receptors. And if those receptors are all bound up, then there's not going to be any free receptors for acetylcholine to bind. Okay, so what they do in the hospital, they say, keep moving your arm like this. And over time, all of the free receptors are going to be bound, or most of them, and so the patient gets weak. So what can you do to treat these patients? Well, you can try to get more acetylcholine in the cleft, right? So if there's any free receptors, you're trying to be able to bind them, and the only way to really do that is to upregulate the amount of acetylcholine. This isn't a great treatment, to be completely honest. It's just, it kind of helps. So if we know that acetylcholinesterase is what breaks down the acetylcholine, if we can give something, an anti-acetylcholinesterase, also called an anticholinesterase, if you could give something to block the enzyme that breaks down acetylcholine, then you'll have more acetylcholine for binding. Okay, again, this doesn't work that great because at the end of the day, you have a bunch of autoantibodies that are binding to these receptors. So even if you put a bunch of extra acetylcholine, there's still not a ton of receptors that are available. Okay, so but in principle, if you can increase the amount of acetylcholine, maybe you can outregulate or off-regulate the amount of autoantibodies that are bound. Okay. And this kind of goes into the same thing we were saying. So if you block acetylcholinesterase, you're going to end up increasing the amount of acetylcholine. You're not breaking down that acetylcholine, okay? So there'll be more acetylcholine that could bind, right? And you can kind of see that here. This is that ptosis, you see, but these autoantibodies will bind to these receptors, postsynaptic receptors. And you can see that here. So if there's not a lot of free receptors to be bound, there's not much you could do. The only thing you could really try is to upregulate the acetylcholine to help with binding. All right, so how do you diagnose this? These are the kind of things you need to know for this exam. Not too much detail, but kind of like first line treatments and diagnosis. So you give edrophonium. For treatment, you can give neostigmine or pyridostigmine. Now, the interesting thing is, why don't you give edrophonium for treatment? Well, edrophonium is like super short acting. So they use it for diagnosis. It's kind of crazy. When the patient comes in, they give them edrophonium and they feel great for about a minute, right? They're like, oh my God, I feel like I'm back to normal. And then the edrophonium wears off, right? So that's why it's used for diagnosis. These drugs aren't that great, but they're more longer acting. So that's why that's the case. It fixes things for a little while, the edrophonium, but it just has such a short half-life. All right, try this one. Again, use this exam use everything you can to your benefit. They don't tell you the patient's a farmer just because, okay? There's a reason they say stuff like that. All right, so it looks like he's got some sort of parasympathetic overdose, right? These organophosphates, that'll do it. So is parasympathetic overdose or a muscarinic overdose or a cholinergic overdose? Those are all the same saying the same thing, right? So these are all parasympathetic symptoms. Now, here's a good one. Why is he sweating? Wait, I thought we were doing parasympathetics. Why is he sweating? Because remember, in a muscarinic overdose, we said even though sweating is a sympathetic response, it has a muscarinic receptor at the end. Okay, so that's a little trick there because these organophosphates are muscarinic agonists. Okay, so it doesn't care if it's parasympathetic or sympathetic. It just happens to be that most of them are parasympathetic, but the sweating response is sympathetic, but has a muscarinic receptor. Okay, so that's why that. But all of the other symptoms you're going to find, bradycardia, right? Pupils are constricted. These are all parasympathetic symptoms. So what do you want to give the guy? Well, you want to be able to block the M3 receptor, and that correlates directly with the pupils. So I think, did I put it again? Okay, let me go back. It goes back to that slide from first aid. Oh, yeah, this, right? So M3, they asked specifically about constriction of the pupils. So you'd have to know that's M3. Another trick, M2 is usually on the heart. So whereas beta 1, one heart, beta 1, M2 is primarily the heart. So you can, and M3 does most everything else, typically, okay? So you could just commit that to memory. Yeah. All right, and right, so again, these organophosphates, muscarinic agonists, cholinergic stimulation. Right, but just remember the sweating, even though it's a sympathetic response, it's got a muscarinic receptor. So that's why that's that. All right. So treatment wise, oh, sorry. Increases acetylcholine muscarinic receptors, right, okay. So what's the treatment there? You can give atropine because atropine will be a muscarinic antagonist, okay? So the reason these organophosphates are working like that, because they actually work as an acetylcholinesterase inhibitor, similar to the treatment for myasthenia gravis, right? But this is just way rampant, like you would never use something like this. But yeah, so, and then you get increased acetylcholine because you can't break it down with the enzyme. And if you get too much acetylcholine, you get these muscarinic, cholinergic, parasympathetic symptoms. So you don't want to give some sort of sympathetic thing to out-regulate this. You want to give a muscarinic antagonist. You want to antagonizing the thing that's overriding the system, okay, always. All right, try this one. Right, so parasympathetic, cholinergic, same thing. What's it going to cause on the pupil? Meiosis. Now, if you get these words confused, meiosis is a smaller word than mydriasis, so the I has to be smaller. So that's pupillary constriction. Mydriasis is a bigger word, that's pupillary dilation. So they say, how big does the I have to be to fit the word in it? Mydriasis has to be bigger. So that's always dilation. All right, and then pilocarpine is a partial muscarinic agonist. They use it topically for glaucoma or intraocularly. All right. Oh, this is a tough one, but there was a line in your notes that had something. Right, so again, y'all will get into this a little more. Don't get bogged down with this in term 4, but the blood pressure, on the actual blood vessels, these vascular endothelial cells, if you're injecting acetylcholine, that's parasympathetic. So you're thinking more of a vasodilation, vasodilatory effect. So you activate these muscarinic receptors, and that'll cause the vasodilation. This is where it was actually in your notes, but again, I wouldn't get too caught up with this. As long as you know that M3 is going to be that cholinergic response on the vasculature, right? Remember we said M2 is primarily in the heart, M3 does pretty much everything else. Okay, so that would be how to do that. And again, y'all will get into it in term 4. Nitric oxide is always, it vasodilates. So that'll happen. Anytime you vasodilate, you're going to decrease the blood pressure. All right, so nasal decongestant, probably pseudoephedrine, right? That's over the counter. If you say it is an alpha-1 agonist, right? Adreno, right? Again, that should all make sense. This is all sympathetic, right? So if we know alpha-1, what's our mnemonic we use? Kick, kiss, right? So alpha-1, alpha-2, beta-1, beta-2. Kick, Q, I, S, S. So alpha-1 uses the GQ system. So you still need to know what the GQ system does. Remember, GQ goes through the phospholipase C and goes through DAG and IPG and to overall to increase calcium, right? So again, use the kick-kiss model here to remember that. And as always, star this, you need to be able to whiteboard this out, knowing which one GQ versus GS uses which intermediates. There's no crossover. GQ uses phospholipase C to end up making DAG, which makes protein kinase C. IFP3 directly increases calcium, whereas GS is activating GI is inhibitory of adenylate cyclase, end up making C protein kinase A, increase calcium. Okay, need to be able to know that.
Can I ask a quick question about the
Yes.
previous question? So would they have to specify if they want it in a skeletal muscle or if it's going to be because
not necessarily. It'll all be alpha-1. So alpha-1, regardless of where it is, it's going to be.
Oh no, I'm talking about the previous question with the blood pressure decreasing.
Yeah, they would. Yeah, for sure.
They would. Okay.
Right. But I mean, technically, blood pressure decreasing, you're talking about the vasculature, right?
Okay.
Directly. Yeah, I see what you're saying, but skeletal muscle. Yeah, but no, I mean, yeah, because they give you the blood pressure directly, you would need to know that this is what we're talking about. Like that would correlate to the vasculature. But
Okay,
sure, if
got
they
it.
gave you some other system, then yeah, it could be different. Oops, let's see. All right, here's a good one. So the question is, what does this child probably have to take? Albuterol, right? Beta-2 agonist. So what are you not going to give the guy? You're not going to give him a beta-2 antagonist ever, okay, right? Like you can't, that's a good way to lose your license. Like if he needs a beta-2 agonist to survive, you can't give him a beta-2 agonist, this antagonist. This will cause bronchoconstriction and who knows how bad it could get, right? So yeah, just be aware of things like that. Right.
Brady, you should also
Yep.
understand that the propranolol is actually non-selective. That is why it's avoided in other places. It's actually non-selective.
Right. So, but we're primary. I mean, yeah. So the beta-1 effect might be fine on the heart, but the beta-2, blocking beta-2 is the problem. Okay, so you can't block beta-2. If you block beta-2, this will cause the bronchoconstriction. That's what we're worried about. Technically, you really stay away from beta blockers in general with these kids because even if it's beta-1 selective, it'll be like 60% beta-1 and 40% beta-2. So you still can't give the kid like a 40% beta-2, even if it's beta-1 selective, Like, it doesn't mean that it's only beta 1. It just selects for beta 1. So it still has a beta 2 effect. But this is a good example for y'all because any sort of blocking of beta 2 is contraindicated. You don't want to give that to this kid with albuterol. All right. All right, did we diagnose, what's this patient got?
Pheochromo.
Yeah, pheochromocytoma, which is funny because it's like, we joke about it because like we talk about this disease so often, but like you probably never see it in practice. Like if a patient comes in with these sort of vitals, like they could be on drugs or something, they're much less likely to have some sort of rare tumor, but we talk about this thing all the time. But anyway, anytime you say VMA in the urine, those are breakdown products of catecholamines, which means the patient is making excess catecholamines. So these are these episodic problems that they have. You can see these are all sympathetic or adrenergic symptoms that this patient's getting. So what you want to give is something that's going to block the alpha response, because that's what we're worried about here. So you can see this is from first aid, and you can see the pheochromocytoma in the medulla here. So the first thing you want to give is phenoxybenzamine because you want to give an alpha blockade. Then you can actually give a beta blocker after that, okay? But the point is you have to give an alpha blocker before you give a beta blocker here, right? And I'll show you why. So this alpha is going to cause constriction, right? That's going to cause vasoconstriction, okay? The beta, even though you're going to you're going to get symptoms like tachycardia. So you want to block the beta 1. But when you give a beta blocker, you're also going to be blocking beta 2, okay? Now, we said beta 2 has an effect of vasodilating. So what happens if you give a beta blocker before you give an alpha blocker? You will get massive vasoconstriction, okay? Because this alpha 1 is going to be the only thing going on, okay? So the point is you need to block the alpha 1 first with the phenoxybenzamine, then you can worry about the beta receptors, okay? You can't give a beta blocker first. Okay, I hope that made sense. Anyway, first line treatment, give phenoxybenzamine. Yep.
Are beta blockers always indicated? I was having this discussion the other day. If you give the alpha blockade, couldn't it theoretically lower the pressure enough? And if it's stable enough?
Yeah, technically, yeah. So I think in practice, they'll go ahead and give the beta blocker, but I guess it depends on the severity of it. Yeah, for sure.
Well, you wouldn't just discharge a patient with both?
You'd probably try to have the surgery if possible. You could give them something temporarily. Yeah, to be honest, I'm not 100% sure. But I think because you do have that beta 1 effect on the heart rate. So I think I would think you would actually go ahead and give them a beta blocker as well, as long as they take the alpha blocker first with it. Just because that beta 1 on the heart is pretty strong. So they're gonna get tachycardia really bad. So yeah, but ideally you admit them for surgery in this situation to get it out. There are some, if it's inoperable, I know that they do some sort of long-term treatment, but ideally you need to get this out. All right, so phenoxybenzamine, yeah, prior to surgical removal, of course, because you don't want all those excess catecholamines spilling into the blood during surgery. And I guess, yeah, if it's inoperable, you can go ahead and use it. To be honest, if these patients even show up at your door is a blessing, because this is really bad. They usually, by the time it's diagnosed, they're in bad shape, if not dead already. All right, try this one. Your first goal every time when you read these is to diagnose the patient, right? So somebody diagnose them.
Klinefelter syndrome.
Exactly, right? Got an extra Y. I'm sorry, an extra X. X, X, Y. So yes, he is a man. He's got a Y, but he's got extra feminine characteristics, right? So what's going to be wrong here? Low testosterone levels. Okay, that's why these people present with female characteristics. Now, what's interesting is why are they tall? As it happens, and y'all will learn this later, in the presence of low testosterone, you get what they're called eunuchs. They actually grow even taller, which doesn't, it seems counterintuitive, like testosterone should help with growth. But as for skeletal growth in the bones and the long bones, low testosterone will actually cause you to get a little taller, if y'all were curious. But yeah, so present with gynecomastia and feminized features, and also infertility, testicular atrophy, okay? Now, we talked about this last time. You know that when we talk about this, I show it, let me see if I added it here too, the little trick I use. Okay, no, I had it in the last one, okay. So the trick I use, Klinefelter's usually happens in meiosis 1, all right? And the trick I use is, you skip the first X when you look at these. But if the next two are one of each, right, one X and one Y, it usually happens in meiosis 1, okay? If the next two are the same, say XX or YY, two of the same, it usually happens in meiosis 2. Now, a lot of these people don't live very long. Klinefelter is one of those exceptions. Turner syndrome is an exception. Turner syndrome doesn't count really towards this, it's X, so it could happen in meiosis 1 or 2. Okay, the one they tend to ask about is Klinefelter's. It usually happens in meiosis 1. Somebody tell me, did it happen in within mom or within dad? Where was the problem? What did dad give? The Y, right? The Y is fine. He had, the patient ended up getting an extra
Mom.
X, so it had to be through mom. Yeah. What about this one? XYY. Where did the problem
Dad.
happen? In dad, right? Can't tell with XXX, right? Because it could get either one from mom or dad. So just remember that. They could ask you that. They'll ask you Klinefelter's, and then they'll be like, where did the problem likely happen? Meiosis 1 of mom, okay? There are exceptions. That's just generally how it works. We're not going to go through this again. We did this last time on review, but you could see if there's a problem in the non-disjunction in meiosis 1, you get these two separating here. If it's not until non-disjunction 2, it's at this level that they don't separate, okay? And then trisomy rescue is the process of kicking out one of the extra chromosomes. It happens at random, and sometimes this could lead to, like with the imprinting problem, it could end up with a disomy, like a uniparental disomy. So if y'all remember from when we talked about Angelman syndrome and Prader-Willi, right? That's usually the example they use for that. All right. So they give you the symptoms, right? The presentation, small lower jaw, abnormal feet, and hands that are clenched. These are rocker bottom feet. So these are how it works. The way you can remember this is Patel, right? So puberty is usually at age 13. Election age, you can start voting at age 18. And drinking age, you can start drinking at 21. But these are the three trisomies they tend to talk about, okay? And y'all learned Huntington's is that polyglutamate repeat, but here you could see these. I think I have a slide from first aid talking about it, because sometimes I get Patel and Edwards mixed up. Remember, Patel will present with the cleft lip and cleft palate, and here's that little trick I use: puberty, election, drinking age. But Patel will present with cleft lip, and cleft palate. So that's a good way to remember that. Low set ears is Edwards syndrome. Okay, so y'all get a question like this. Problem with Down syndrome, a lot of times they are predisposed to additional cancers as well. AML, ALL as childhood cancers. So it's good to know that. Robertsonian translocation is another buzzword for you that tends to happen. Those are when those little acentric nubs on the end of the chromosomes get lost. So that's another one that's indicative. For Down syndrome, they actually get early onset Alzheimer's. That's because the gene that gets mutated for Alzheimer's is also on chromosome 21. Okay, so it's one of those things that's fairly common in the population, so you need to know about it. All right, I'm not sure y'all went over these markers. If y'all have, it's good to know. If not, don't worry about it, but some of these exceptions, if you have a kid with Down syndrome, usually the beta HCG is elevated, okay? That's a big differential for those. And then, yeah, I'm not sure y'all did those yet, though. I just wanted to put it in there. All right, and again, Robertsonian translocation. Sometimes these little acentric nubs here get lost like this when they have a translocation. And if that's the case, you could end up with certain problems. Down syndrome, some of these y'all will get through later. Y'all have to know these. 922 always relates to the Philadelphia chromosome. So it puts this BCR gene next to this ABL gene. Tyrosine kinase activates the cell, so you end up getting cancer, right? So you're by combining these, BCR kind of promotes anti-apoptosis. So if you get that, then you get these cells run rampant in these blood cells. 814 is always Burkitt's. Remember c-MYC, we talked about that with the MYC-MAX combo. MYC is always expressed, meaning you are making cells you don't want to be making, or too many of them, so it could lead to cancer. Again, y'all will get into this a lot more later, but these are two common ones, 922 and 814, that always come up. Robertsonian translocation, again, those little acentric arms kind of not fall off, but the two acentric arms will come together and the two long arms will come together. And if those little acentric nubs end up getting lost because they're so small. All right, try this one. Somebody diagnose them.
The George?
Yes, exactly, right. So we know the catch-22 mnemonic, chromosome 22, and they tend to get hypocalcemia. So do I have a slide? Okay, there it is. So they tend up getting hypocalcemia. They get thymic aplasia. The thymus is where a lot of your immune system develops. You develop T cells. And you also lose these, well, y'all will learn it later, but these parathyroid cells, and that helps to make upregulate your calcium in your blood. So if you don't have that, you tend to get hypocalcemia. So these are those kids. Again, you need to know it's chromosome 22, but this is the most important thing. Catch 22, it's a deletion. They'll have cardiac abnormalities, so they'll have shunts and stuff like that. Abnormal face, these facial features. Thymic aplasia, so again, the thymus doesn't develop. Parathyroids don't really develop either in the neck. They can get cleft lip and cleft palate. If you don't have the parathyroid glands, you can't regulate your blood calcium. So they like to use hypocalcemia. Some symptoms of hypocalcemia are tetany, right? So the muscles lock up. So if they give you something like that in some sort of genetic patient, like a deletion patient, they like the hypocalcemia aspect of it to test on. All right, let's try this one. Right, so nobody likes looking at all these graphs or all these pathways, but PRPP, if you look here, right here, it helps with this pathway when you're making your purine. So it is one of the precursors to making this. HGPRT, do you know what this kid ends up having? Very characteristic.
H9.
Right. Do y'all know one of those characteristic features they always talk about? Self-mutilation. Yeah, very strange, right? When you start talking about making purines, how does this affect in the brain, right? But they'll say like they bite their lip, they bite the tips of their fingers. So it's classically self-mutilation. But for whatever reason, I'm not sure science even knows exactly why they do that. But yeah, so you could end up getting that. HGPRT is one of those common things, but you could see that here. PRPP is the precursor. But if you don't have HGPRT, you get increase in the precursor, so you can't actually start making those purines. Okay. Here's another one. Yeah, again, this is something y'all are going to come across a lot later, but through that pathway, the ortic aciduria is a metabolic defect, but with normal ammonia, you can see this ortic acid forms here. So this is through the same pathway. So you're going to get impaired formation of some of these precursors, thymidine, cytosine, and uracil. Okay. Right. I don't think y'all talked about some of these. Some of these drugs are going to become important later. I don't think y'all talked about those. Methotrexate, maybe y'all did. Did y'all?
Yes, we did.
Okay. Yeah, these are going to keep coming up. So things like methotrexate with dihydrofolate reductase, 5-FU, which is thymidylate synthase, and hydroxyurea ribonucleotide reductase. Point is, they're anti-cancer agents. Why? Because if you can't make purines and pyrimidines, then you can't form new cells. You can't replicate. So helps to slow it down. Problem is, can't give them to pregnant women because the kid needs to be formed. This is through that folic acid pathway, right? So if the mom gets it and she can't properly make folic acid through this process, you can lead to neurotube defects. Another good way to lose your license. Don't give that to pregnant women. All right. Right, we did this one last time, right? For the last review. Anytime you silence a gene, you put a bunch of big methyl groups on there. If you have methyl groups on there, the transcription factors can't bind because these bulky methyl groups are in the way. So that's a good way to silence the gene, right? This is from last time as well too. Put a bunch of methyl groups there, this complex can't bind, okay? Acetylation and deacetylation. Remember, the process of being deacetylated means it's charged. If it's charged positively, it can bind up the negatively charged DNA. Okay, if it does that, you can't transcribe because the DNA is all wrapped up. Now, if you acetylate it, you take off this negative charge. So it's not going to bind the negatively charged DNA. Therefore, the DNA is free to be transcribed. Okay. So just remember, when we talk about Mendelian inheritance, we have those rules, right? There's no influx of people. There's no genetic variation or mutations. Everything has to be standard. The problem is, in real life, there's a whole bunch of things that go into things that happen, like not only your genetics, but like your work environment or like, nature, nurture, everything comes into play. So typically things that are multifactorial, you can't use Mendelian properties, right? This p squared plus 2q plus q squared is nice and all, but like you also have like a trillion other factors that come into daily life that that go into play as well. All right, and excuse me, I think this was a DNA, but obviously it's not that simple Mendelian pattern, right? It has a lot to do with things that are, out and about. All right, and y'all have come across Dr. Trotz's nutrition lectures. Those tend to be closer to the exam. They like to put those in there. She keeps them pretty straightforward. So what's good about Mediterranean diet? She loves oleic acid. Just better for you than in the Western diet, right? Let's see. Oleic acid, right, is right here. So monounsaturated. Remember, those are better for you. Not that y'all need to really know. They have kinks in the chain, so it's easier to break them down. Saturated fats don't, so they're very it's harder to break down the fats, so they end up clogging up your arteries and stuff. All right. All right, so they tell you these things for a very good reason. Right. So what is going on here? Somebody diagnosed the patient. Bonus points if you say it correctly.
Kwashiorkor?
Kwashiorkor.
Kwashiorkor.
Very good. I'm impressed. Right. So it's a protein malnutrition. Y'all will learn a lot about this later, but the point is that protein helps to keep the fluid in the vessels. If you can't make protein, fluid goes everywhere. They get this protuberant belly, also called ascites. They get edema, swelling of the legs, just because that protein has an effect of holding all of the fluid. Y'all will get more to it later. We'll talk about it another time. You can see this protuberant belly, okay? Marasmus is a complete a complete caloric malnutrition, like this little child here. But you can see the kwashiorkor, this is a protein malnutrition. That's why all the fluid is building up in the stomach. All right. So HPV, it's a virus, E6 and E7 is affected, but we know that RB and P53 are those cell cycle regulators, right? They are tumor suppressors at the G1S checkpoint, so they help to deal with cell cycle regulation, right? P53 is a culprit in almost 50% of the tumors out there. That's how important it is, okay? So when it's working, it can tell the cell to stop replicating. If it's not working, the cell kind of just does whatever it wants, okay? So super important. Right, and then we talk about the idea of tumor suppressor genes. If you lose the function of a tumor suppressor, this tumor can replicate without any regulations, right? So you're losing the function to suppress the tumor. Unfortunately, y'all have to just memorize these. Y'all are going to learn about them later, but at least the ones that are bolded here are going to be important just to kind of know what cancer they go with. Right now, they'll be straightforward buzzwords, so you know it or you don't. Later on, y'all will get into these in much more detail. BRCA, breast cancer, is always a big one because it's very common. Yeah, RB, y'all know retinoblastoma. Wilms typically happens in the kidneys as well. Neurofibromatosis, if you haven't seen a picture of that, look that up. Those are little tumors that form on the neurons. It's pretty crazy. So yeah, you just need to commit these to memory now. Again, y'all are just touching on this now. Y'all will learn about a lot about this later. These are polyps that form in the intestine, in the large intestine, but they do present very differently. HNPCC has fewer polyps. It tends to be on the right colon, whereas familial adenomatous polyposis tends to be on the left side. There are a lot more. Because there's a lot more, they tend to lead to pretty much always will lead to cancer formation because you have thousands of polyps, which is thousands of opportunities for mutations. So this needs to be addressed, okay? But the important thing here, ABC relates to FAP, and then these MSH ones and MLH tend to be with H and PCC. But H and PCC, if you remember, is a DNA mismatch repair. So you can't repair the DNA. So you get these microsatellites. So you know the DNA has a process of going back and repairing these little mutations. If you have DNA mismatch repair with H and PCC, you end up getting these microsatellites, and these can lead to polyp formation. Okay, all right. Try this one, somebody diagnosis. Bonus points for real this time if you can say this.
Xeroderma pigmentosa.
Killed it. Yeah, that's right. So these kids can't go in the sunlight. We all make these thymidine dimers, okay? We all make dimer formations, but our body can go back and fix it. These kids are not able to fix it, so they get really severe sun issues. Y'all have probably seen, maybe didn't know the name of the disease, but y'all have seen these kids that have to be on the umbrella, have to stay inside and stuff. And that's because they can't correct these thymidine dimers, okay? This is considered a nucleotide excision repair. So whereas we can, these thymidine dimers that are on the same strand, right, that form, we can go back and excise, we can take them out, and then the DNA polymerase can go fix it, but these kids can't. So this is problematic. And there you go. Yep, so you can see it's very severe. So got to keep them out of the sun, right? They can lead little tumor formations. And this just kind of goes into the differences between base excision repair, which is very similar to nucleotide excision repair. base, they just kind of snipe in and just take one out, where nucleotides will take out a little section. But yeah. Yeah, so just different processes. Obviously, for the amount of replication our body goes through, there's, a few mutations per millions, but we still have to correct those because we go through billions and billions, right? So if we weren't able to correct them, we'd all get cancer very young. So this is what happens when these mismatch repair processes don't work. All
If
right,
the
try
base
this.
is messed up, is there a glycosylase for each different type of base, or is it just your cell that has one?
No, so I think the process is like they can all take out the endonuclease. They can all take out any problem, but then the DNA polymerase will come in. Yeah.
Okay.
Because you remember you use like DNA polymerase 3 to go and check things like this, right? So once DNA polymerase 3 is like something's messed up, it goes backwards like that 3 to 5 prime exonuclease check. And then you can just kind of take them out, and then you I'm sorry, DNA polymerase 1 does that. And then DNA polymerase 3 can come through and just drop the correct base in there. You won't need to know that, but yeah. All right, diagnosis.
Duchenne's muscular dystrophy.
Right. So what's the other one? That's very similar.
Becker's.
Which one's worse?
Duchenne's.
Right. Yep. So you're going to get this dystrophin. In Duchenne's muscular dystrophy, they basically have none of it, right? So they're usually wheelchair bound by 12. They die by 20. It's really sad. With Becker's, they have a little bit of dystrophin there. They can get to reproductive age. So what that means is that even though this is a genetic problem, these kids that have Duchenne's, they're not replicating. They're not having children, right? Are reproducing. They're not reproducing. So this is actually a de novo mutation that tends to happen in these kids. Okay, so you're not going to get it passed along, even though it does have the genetic basis of it. It's usually de novo. All right. So yes, one of the things they like to talk about, these kids have problems with their pelvic girdle muscles, with their lower extremities. They use what's called a Gower maneuver to get up. You can look at it on YouTube. They kind of use their hands to like walk up to an upright position. They also have what's called pseudohypertrophy of the calf. Their calves look really big, but it's like fatty infiltrate in there. It's not actually muscle. So that's a characteristic thing. Right, and I put these in gray. I wasn't really sure if y'all covered it yet, so don't worry about it if y'all haven't, but y'all should know the other ones. All right.
Brady, I have a question.
Yes, yeah, what's up?
In Becker's, will they also have high levels of the creatine kinase?
Yes, but not as high, right? Because they're not as deficient in their muscle break. So creatine kinase is always representative of muscle breakdown. So where in Duchenne's they'll have a lot of it because that dystrophin can't hold it together. With Becker's it'll be high, but it won't be as high.
Thank you.
All right.
I have another question. Is it possible to see the Gower's maneuver in Becker's as well, or only in DMD?
Yeah, probably. I think so. But again, Becker's is a little bit of a spectrum where you have like maybe 30 to 50% of the dystrophin there, whereas Duchenne's is like almost zero. So they probably have an easier time getting up, but I would imagine it would be similar. Yeah. All right. Now learn about cystic fibrosis. Remember, you have that the chloride channel or that transmembrane receptor that's messed up. Because the chloride can't get through properly, sodium can't get through properly, which means water can't get through properly because water always goes with sodium. So if that's the case, you get this mucus buildup. This mucus buildup is a problem specifically in certain organs. In the lungs, you get too much mucus, you're prone to bacterial infections like Pseudomonas. Chronic pancreatitis, this mucus gets built up in the ducts where the enzymes for digestion go from the pancreas to the stomach or to the intestine. If those ducts are clogged, you have problems digesting things because you don't get the enzymes there. So they talk about like fatty stools. They can't properly digest fats. These patients are chronically malnourished. A lot of them have feeding tubes just because they can't get the nourishment because those enzymes aren't able to get to where they need to get to. They also have obstruction of the vas deferens, which means they have sterility, okay? And remember that CFTR or cystic fibrosis shows allelic heterogeneity, right? Allelic means that you can get mutations, different mutations along the same gene. Locus heterogeneity is mutations on different genes that can cause the same phenotypic effect, but allelic heterogeneity has to do with problems on the same gene. So many places on the CFTR gene can have a mutation that will all produce cystic fibrosis. The primary one is the 508 one, the F508. And that's the one that they most of the time talk about. That's the most common one, okay? But it tends to have to do with this phenylalanine problem. Right, and y'all talked about compound heterozygosity. I'll quickly touch on it. So what I'm saying is, let's say mom has a mutation here, right? So that little a mutation is there, and dad has a mutation here. So let's say 1/4 chance kid gets little a, right? This is not the same mutation, right? One may be the 508 and one may be like the 202 or whatever, right? But this kid's still gonna get cystic fibrosis. That's what compound heterozygosity. 2 mutations, different places on the same gene that can cause it, okay? So by definition, you can't have compound heterozygosity without allelic heterogeneity. Hope that makes sense, right? Because for it to be a compound heterozygote, you have to have 2 mutations on the same gene. The parents came together, okay? So they'll never be in the same question.
Would that be less severe if, rather than both having at the 508 position?
Hard to say. I mean, knowing that the 508 is the worst of the prognosis, maybe, but it's really hard to say. I don't know. Yeah. All right, sickle cell. Right, so this ends up having these kids get hemolytic anemia. These cells aren't properly formed. They end up sickling. And what ends up happening is when the red blood cells lyse, you get increased bilirubin. And that's why you get this yellowing, this jaundice. That's all that excess bilirubin that's floating around because the cells lysing, splenomegaly, because the spleen gets congested with all these sickled cells, right? So I think I have a better picture coming up. These sickled cells get clogged up. They end up getting autosplenodigestion, autosplenectomy because of splenic digestion, autodigestion. And again, a lot of times, I'm from New Orleans, there's a big sickle cell population. We used to work it down there. And it's so sad because these kids go through these pain crises, right? And you have to give them morphine, it's that bad. So unfortunately, these kids get dependent on these strong opioid medications at a young age just because it's such a difficult thing to treat. So you have to treat them symptomatically. All right, they love to ask this. They're very specific. The mutation here is a glutamic acid replaced by a valine at the 6th position of the beta globin chain. They like to ask that specifically, okay? It is a point mutation. It is a missense. What does that mean? Missense means that you change this glutamic acid to a valine. You change the amino acid. By changing one base, right, at that 6, you're changing the sequence there. Typically it's one base, and by changing one base, you change the amino acid sequence. Okay, so glutamic acid is negatively charged and valine is neutral. Okay, what that does is it ends up making a hydrophobic pocket here because it's expecting to have this charge on the outside, but it doesn't. And so since it doesn't have the charge, this little portion of the cell wall, the cell membrane, wants to get into the hydrophobic pocket. It wants to get away from the water, right? It wants, since the water's charged, or since it's water, it's, you know, it wants to get into the lipophilic or the hydrophobic area, right? Kind of like the cell or the phospholipid bilayer, right? It stays separate. So because it wants to do that, it makes the cell sickle, so they tend to clog up the vasculature. All right. And then we could see, this is what I was mentioning about Duchenne's muscular dystrophy. This is that pseudohypertrophy of the calf. Right. I think somebody, there we go. Thank you. All right. Let's see. Again, the Gower sign, low reproductive fitness, meaning they usually don't live to reproductive age. That's why these are typically de novo mutations. So good to know this for sure. And the difference here. So remember, when you think about it, a frame shift mutation is always really bad, right? Because you're shifting the coding sequence down one, which means every subsequent amino acid that's laid down is going to be messed up, right? Whereas in frame, you're restricting it to one set of one amino acid, right? And then everything else kind of still follows in the same order. Okay, so that's why Duchenne's is worse than Becker's. All right, that's all I have. Lindsay's going to go through some questions with you guys. Now, she doesn't post her questions just so that y'all don't have the answers, so that y'all can go through them. But once I post everything finalized, I'll post all of her questions as well. So we could take a few-minute break if y'all want. And I will stay back after. We'll do pedigrees all day. I'm so aggravated right now. Just kidding. But yeah, we'll just take a couple minute breaks and Lindsay can load everything up.
Yep. Okay, cool. We'll go ahead and go. It's on the recording. So, okay. First cue. I only have a handful of answers. Anyone else want to give it a shot before I? Okay, we're split between two, so it's okay. Okay, so the answer is double minutes. This is straight from the notes. It's a definition. No, it's not conceptual at all. The reason I put this question on here is to demonstrate to you, you need to know what the examples are associated with all of those gene defects. So breast cancer, this is associated with the double minutes. It's straight from your notes. I may have put a slide, did I? Yes, I did. So HER2 overexpression, so the amplification is detected as double minutes. So please know this example. Please know all of the examples when you're going through and you're seeing these genes, you're seeing these mutations. Please be able, please. It'll give you a decent number of points if you pay attention to the examples of I can't talk today, guys. I've been on Zoom since 9 a.m. Examples of the different mutations, just know them. Okay, next one. You guys are all getting this. I would hope that everybody associates this with DeGeorge by now. So the 22Q11-2 deletion, it's DeGeorge. Please associate it with it, but don't just associate. I think I have a slide. Yes, I do. So know these examples, please, please, please. Again, this will also give you a few points. So know that the 922 reciprocal translocation is CML, 814 is Burkitt lymphoma, and then the 46 XX, that one is Krutishaw. So again, this will give you a handful of points on your exam if you memorize all of these examples. Now, this question gets people every single time I ask it. It says the pain that is felt with the rebound tenderness. And we'll talk about that in a minute when everybody has had the chance to answer. We have a nice little spread, so. Okay, so before I show you guys the answer, what is the difference between the somatics and the viscerals?
Visceral is more organ.
Mm-hmm. Yes.
Outside.
Yeah. Somatic is going to be more like skin pinpoint. So when you're doing an exam, if a patient can point with like a finger and they know where it is, it's most likely somatic, but visceral is very nondescript. It's organ, it's pain from the organ. So when we're talking about pain felt with the rebound tenderness, you probably guys haven't gone into this, I don't think, but rebound tenderness, that exam, you go in the right lower quadrant and you press down deeply and you release it very suddenly. And if you have pain on release, that's positive rebound tenderness. Essentially what you just did is you aggravated the appendix. So an appendicitis, an itis is an inflammation, so inflammation of the appendix. So the appendix is swollen, it's inflamed. If you press down on it, you're essentially aggravating that inflammation. So when you release it, you're feeling that pain from the organ because it's aggravated. So that means what? It's visceral or somatic?
Visceral.
It's visceral. So here we are talking about visceral afferent. So the neurons that are conveying the pain felt with the rebound tenderness. We are talking about the afferents. Why is it afferents? Because the afferents are going to be going back to the nervous system. So when we're talking about efferent versus afferent, always think about the spinal cord, always think about the nervous system. So when you're thinking about the nervous system, the nerves that are going from the spinal cord to the target is efferent because it's exiting the spinal cord, whereas the afferents are going to travel back to the spinal cord. That's why we're talking afferents, because the afferents are going to be responsible for pain sensation. So that's why it's visceral, organ, afferents, taking it back to the spinal cord, because then we are, it's a sensation, it's sensory, it's not motor. So this is just the classification. Yes, please, if you know motor versus sensory versus the integrative, you'll get 2 to 3 points on your exam, like the pseudo unipolar neuron, the bipolar, just examples of them and what they are. You will get a lot more of this in term 2. So just understand you're getting a very surface level introduction so that when you get to term 2, it makes more sense. Yeah, most of you guys are getting this. I'm gonna give it a little bit more time for everyone to answer. Okay. DRG, the dorsal root ganglion. So why is it this? Remember, we're at the level of the organ. We're sending nerves back to the spinal cord. If you remember, when you're coming back to the spinal cord, there's that little not looking thing right before you get back to the actual cord. That's the dorsal root ganglion. The dorsal root ganglion is a collection of cell bodies. So postganglionic cell bodies are going to be there. And then you have the another nerve that sends it back into the spinal cord to ascend up to the CNS. So dorsal root ganglion. Okay, so this is a picture of it. So you see that everything that's coming back into it, you have the cell bodies in the dorsal root ganglion. So sensory cell bodies. So anything sensory coming back, that's what it is. Okay. So when you are looking at these questions, I always read through the whole question, but make sure that you just focus on the stem, because that's what's going to give you, that's what's going to focus you in on. So this first part, you haven't really learned in term one, but it doesn't matter because that's not the information the question is asking you. It's asking you, what is the mechanism of methotrexate? Because the vignette tells you that she's prescribed methotrexate. Now it's saying, what is the mechanism of action of methotrexate? So just to let you guys know, if you read a long vignette and you don't understand what the vignette is talking about, it doesn't matter, because sometimes in FTM especially, what you're really just focusing on is the stem, and the symptoms and everything don't always clue you in on what you want to know. So if you've been stressed out and you see things and questions that you haven't learned yet, just take a deep breath. They know that. Focus on the question stem. So that's my little TED talk right there. And the answer is A. Nothing tricky here. This is really just a definition from your notes. Make sure that any drug they do give you, you do understand the mechanism of action there and what it's acting on, especially when you're talking about the receptors. And Brady did go over it. They don't test you very heavily on that in term one because they don't go deep into farm yet. But what they do give you, know the receptor that it acts on, what happens when it attaches to the receptor, and then if it has a mechanism of action like this, so by competitive inhibition of an enzyme, then you should know it. So this is the accompanying pages from your slides. Let's do this one. I feel like I've seen this sort of graph on almost, not all, but almost all exams that have to do with anything farm related. So knowing the difference between potency and efficacy, and being able to look at a graph is really important, just so you guys know. So please understand that now. If you don't understand that, please reach out to somebody. Okay, you guys are all in consensus. So you are correct. They have equal efficacy. What is an easy way to define efficacy and potency?
Efficacy has to do with the Emax, while potency has to do with the closest to the x-axis, I believe.
Mm-hmm. But what else can we say if we're just talking about your understanding? So you guys are in FTM too, so you're talking a lot about Vmax, KM, all of those things. But if you're just trying to conceptualize this idea of potency, this idea of efficacy, what can you say about the two of them to
How much
understand.
it takes to work, and like,
Uh-huh.
and then for like efficacy, it'd be like, how much is it working? Like,
Yeah. So
Okay.
one of them is going to be kind of the magnitude of it. What would be which one would you say is representing the magnitude of it?
Emax.
That
Max.
would be
Oh,
Yeah. So which
Efficacy.
one is that?
efficacy.
efficacy.
Yeah. Yeah. So the
Yes.
efficacy is essentially, does it work or not? It's the magnitude of it. But the potency is how well it's going to do. So A and B, are they, which part of this is going to have the highest potency? A or C?
A.
A,
A.
because you
Yeah.
want to lower EC 50.
Yeah. And so A has it has the highest potency and it has the highest efficacy. So you know it's really potent. So if you give it, it's going to work really well, but you also know the magnitude of the effect. So, you know, is it going to work at a certain level versus another one? So A would work better than C based off of the magnitude of the effect you see. So if you don't understand how to look at these graphs and you don't know what those terms mean, please spend a little bit of time on it, because it helps you in FTM2, but it also helps you later on, because they don't necessarily reteach this information in depth, but you are expected to know it later on. So, oh, and they love enzyme stuff on here. So look at those graphs. They give you a lot of graphs, and I don't know how many lectures this spans, but if you take a little bit of time on the graphs, you should get a fair amount of questions right on this exam when we're talking about enzymes. So that's just the accompanying slide. SOB is shortness of breath. SX is symptoms. Okay, yeah, you guys are getting this. So it's essentially what is the definition of an agonist? So an agonist is going to enhance or potentiate the effects of the beta-2 receptor. So please know the definition of the two. They love, I'm going to go back to what I said about knowing the graphs, knowing the enzyme graphs. Please know what the different graphs look like for agonist, partial agonist, antagonist. If you put two of them together, what it's going to look like. So please know all that stuff. I'm so sad. None of you probably know what Dodgy Dock is. Even if you're here in Grenada, you probably don't know what Dodgy Dock is. Oh, yay. Okay. Wednesday nights at Dodgy Dock are my favorite. If y'all don't know, Dodgy Dock on Wednesday nights, it's a lot of local food vendors and live music. And so you go and you get tickets and you can try all this different food. And the band that they had there is so good. They're so good. They're so much fun. It's just a big party and it's on a dock, so it's cool. Okay, yeah, you guys are getting this right. It's inhibition of CYP450. Essentially, this is an enzyme that's going to metabolize certain things in the body. So if you inhibit this enzyme, you are not metabolizing it out. So for example, in our person here, if you inhibit the enzyme, it's not metabolizing the alcohol. So the alcohol is staying in your system and affecting what it affects. And so you're tipsy, you get drunk. Conversely, if something were to enhance the activity of CYP450, that means that you will need a higher dose of whatever you're taking. So for example, in pharmacology, a really, really, really big thing you have to understand is inhibition or activation of CYP450, because that will affect dosing of other things that are metabolized by that enzyme. So please know all of the examples they give you for inhibition versus activation of CYP450. You'll get 2 to 3 questions on the exam. It's really just memorization. There's nothing tricky about it, but please know those. Know the inducers and know the inhibitors. So these are the inhibitors.
Stomach. C. Aspirin.
Hey guys, make sure that you are letting others get it. Okay, so you guys are pretty much all in consensus, which is the first time this has ever happened with this question. It's C, it's going to be absorbed in the stomach with a pH of 2.5 in the protonated form. So this is your chart. Brady went over it. He also told you guys the trick. So the 10 to the third, if you know how to set this up, 3, there's not 3 9s, 10 to the second, 2 9s, 10, to the first, 1 9. Why not A? Because it has to be absorbed in the protonated form, not the unprotonated form. So this is an organic acid versus base. So acids are going to be absorbed or soluble in the protonated form. And so even though we are talking the stomach and pH of 2.5, you need to figure out in which area it's going to be protonated, or the highest concentration of protonated, because at any point along the GI tract, it's going to have a certain percentage of protonated versus unprotonated. And so you want to pick the area of the GI tract where most of the drug is going to be in its soluble form, so that it can be hold on, I just got a lot of us. Yeah. What's the difference between B and C? The difference between B and C is the percentage of protonated versus unprotonated. So in B, you're gonna have a very, very, very small percentage of aspirin that is in the protonated form. So you're not gonna get good absorption. Versus C, since it's an acid in the stomach, you're gonna have a high percentage of aspirin in the protonated form. So even though both of these could be absorbed, at a pH of 6, you're going to have a very small percentage that is able to be absorbed, versus at a pH of 2.5, you're going to have a high percentage that is going to be able to be absorbed. Did that make sense? Okay, so acids are absorbed in the protonated form, bases are absorbed in the unprotonated form. So those are the difference between the two. And then be able to reproduce this chart. It's not that hard, honestly. If you sit for 2 to 3 minutes, just know the rule of the 9s. So 3 9s, 2 9s, 1 9. Know the order. And so unprotonated versus protonated. So the 3 columns you need are the pH minus pK, because you need this number, and then probably just unprotonated versus protonated. You don't need the log or anything for your purposes, really. Your questions will be very similar to this, and where you're going to have to use the pH minus the pK and then this. So don't think about this with respect to stomach, duodenum, jejunum. I put that just to put it. Focus on the pH. So pH minus pK. It's pH minus pK. So 2.5 minus 3.5, that's -1. When it's -1, right here, you have 90% in the protonated form and 10% in the unprotonated form. So this is when you're going to get the best absorption of the aspirin, because it's a weak acid. Now, if I'm going to go back to the example of B, so 6 minus 3.5 is 2.5. Yes, 2.5. And so I'm just going to say 2. And so this means that 99% is unprotonated and 1% is protonated. So 1% protonated, weak acids are absorbed, or acids, I need to stop saying weak, acids are absorbed in the protonated form. And so only 1% would be absorbed in the small intestine. So that's why. Look at the percentage of unprotonated versus protonated. Do you have an acid? If it's an acid, it's absorbed protonated. If you have a base, it's absorbed unprotonated. And then you say, okay, well, what percentage is it right now? So where is it going to be absorbed? What pH or weak bases? They're always going to give you the pH. They're never not going to give you a number if it can't be calculated. So they're going to give you the pK and they're going to give you the pH. You will use those 2 values to get this on the left-hand side. So pH minus pK. And then this is going to tell you, the way I remember, this is so dumb, but I mean, the dumbest, most simple things are the things that stick with you and help you remember everything. So H is before K in the alphabet. So that's how I remember it's pH minus pK. And then unprotonated, protonated, if you're setting up your little chart here, I just say up. So like UP up. So that's how I know the order. Like, okay, unprotonated is in this row and protonated is in this row. It's silly, but it works for me. Whatever works, right? Okay. So this is my last question for you. Short and sweet today.
Thank you.
I have a question, Lindsay. If you don't mind? Okay. What if we're not told if it was a weak acid or a weak base? Because I have a question like that. It wasn't mentioned and they only gave us erythromycin. So how do we go about that?
Whatever Brady, you're on mute.
Yeah, pretty sure all the drugs we work with are weak acids or weak bases, unless it's something like way out there. They need to be for that absorption period and to be cleared properly.
Yeah, but in this case, we're not told if it was a weak acid or a weak base. They just gave us the drug, erythromycin. So,
did it give you the pH of it though?
Oh, they gave us a pKa.
Yeah, that's all you need. That's all you need.
Yeah, that'll tell you whether it's a weak acid or a weak base. Yeah.
Can I say something? I actually emailed the professor about this question that she's talking, that she just mentioned. The professor said that was a bad question because they will always tell you that if it's a weak acid or weak base. And then also he said that the pKa of 9, like a high pKa, does not guarantee that it's a weak base. So he said we can find some some weak acid with a high pKa, but he said what, for the sake of the exam they will always tell us if it's a weak base or a weak acid.
Yeah, right. They should do that. Yeah, for sure. Just so you could work it out properly. If you do it the trick or the other way, you still really need to know the P. Okay, so well, technically some of them have multiple pKa's because they have multiple hydrogens, so it gets really complicated. For the exam purposes, they'll let you know.
Yeah, they're never going to leave out information that you weren't expected to memorize.
Any
more
other questions? We could go back through the genetics if I confuse y'all. It's up to you guys if y'all had specific questions about it.
Yeah, or practice questions that you can't figure out, stuff like that.
I posted one genetics question for, I think like that time they was like too long. Let me just find it again.
Wait, you posted a question?
Yeah, it was in the chat, like when we were doing genetics and stuff.
Oh, can you if you could repost it, I'll take a look at it. There was a question, where's the recording posted? We posted on our pages on Facebook, the link to the YouTube page. But there's also on the About section in Scrubs, there is a link to the Tur 1 playlist. The channel's private, so you have to use that to get, you have to use the actual link. Okay. Okay. Yeah, we could go ahead and do this. They won't give you this on the test though, because you really do have, you really have to, I wouldn't stress this. That half sister.
Yeah, and it was like, I was so confused, I'm like, why would you marry half sister first of all, but okay.
They do that because, well, it's called like consanguinity, right? So like it's just because you end up with a similar gene pool. It happens. But yeah, no, I wouldn't stress that. You'd really have to write that out. So, yeah. Again, just for the genetics, at least just remember the 2/3 and the 1/2 rule. I think beyond that, you'd be fine. That's as far as they'll go. And whenever you're trying to calculate that carrier frequency, don't forget to multiply by 2 when you do the 2PQ, okay? Because you're looking for carrier. The thing I was getting tripped up on earlier, make sure you're trying to determine in the pedigree whether it's a carrier or whether it's the disease state, because that'll determine that Mendelian frequency you're looking for, okay?
Thank you guys.
All
We
right.
really appreciate it.
Yeah, no worries.
Just could I throw an idea out there and let me know? So would it be possible if we had like every week like a weekly breakdown, or is that like out of the question?
We have 4 terms that we help out.
Oh, okay. Never mind then. Forget
With
that.
term 5, we do reviews every single week, and then all of them are about 4 or 5 hours. So we have to do it for all the terms. We used to break them up when we were term 2s, and we did them for the term 1s, or we were term 4s.
And we only had
even.
1 term that we were mentoring.
But
yeah.
we literally have to do this every week. And my advice, some of the older reviews that we posted, you can even if it's the long one, the 4-hour one, you can watch the first third of it for the first week.
Yeah.
And then, these reviews we do now, we use the same slides that we've used before. So if you just want to watch the first part of it and you get to a part where you haven't done it yet, just wait off. I mean, that's what I would recommend.
Okay.
But yeah, ideally we would, but we have our own test too. So it's like,
we have our own stuff.
Sorry, it was just a thought. But
No, you're perfectly fine in asking that.
Yeah, just take a look at the older stuff, and I think that'll help you as you go along.
Mm-hmm. Yeah, we used to do it week by week by week when we had time and energy
and cared. No, just kidding. Totally kidding. We love you guys.
Oh my God.
Please, can you go back to the question? It's slide number 27 for me.
Of Lindsey's stuff?
No, like the first ones.
Oh goodness. Okay, hold on. All right, my slides are differently annotated, but which one was it?
It was the one where they say a 27-year-old woman comes to the physician to learn about her recurrent weeks for having cystic fibrosis.
Okay,
the answer was B, 1/400, 1/480.
Okay, hold on.
I think it's slide 27.
Okay, yeah, mine are different because I have them. But yeah, I found it. Hold on. All right. All right, so this
Yeah.
one.
Yes. Mhm.
Okay, let's see. Okay. So she has a niece who is a known carrier. So can we use the rule for this? No is the answer, because for the rule, for the 1/2 rule, the niece would have to have the disease. So I'll preface this with, they will not give you one this hard on the exam, but let's work through it. So niece here as a known carrier. So she's AA, right? It has to be recessive. Well, it could be X-linked recessive, but she's a carrier, so we'll assume it's autosomal recessive. Did it say what disease we could look at? Oh, cystic fibrosis. So yeah, so autosomal recessive. All right. So, so the person of interest, well, it's a sheet, right? This is the person we're curious about. So again, you really have to write this out on the test, so they won't give it to you. So let's see what other information. Niece is a known carrier, and her husband is from the general population. So that is 1 in 3,600, the incidence rate. Population. So we could figure out dads easily right here, but we want to figure out moms. And this is why they're not going to give it to you, because you really need to work this out. So we know that this child is a carrier, right? Now, what's the possibility that this child got that small a from mom and from dad? This is the best we could do under the circumstances. It's a 50-50 chance, right? 50% chance it got it from mom, 50% chance we got the small a from dad, right? This is just statistical analysis. Now we know that this person right here is 1/2, and we know that here, this person of interest shares the same DNA because they came from the same parents, shares 1/2, okay? So that means we can calculate the mom here, this lady with the question mark, the mom, because wait, we want to know rest. Okay, so let's just add this in real quick. We want to know about if they had a kid, right? This is what we want to know. So we know this is mom and this is dad. So mom is gonna, you have to work through the pedigrees, which y'all probably don't have a lot of practice with because y'all won't have whiteboards. So you have to work through it. So this child is 1 times the mom is 1/2 times the sister 1/2. So we did this 1 right here times 1/2 times the 1/2 to get that mom's. So that means the mom is 1/4. Okay, so now that's probably a little bit out of scope, but dad is not out of scope. You need to know how to do this. So if we know that Q squared equals the incidence, right? We want to know, sorry, nope. Q equals the square root of the incidence, right? Okay. No, I was right the first time. So we want to take, to figure, if we know that's the incidence, we want to take the square root of 1/3,600, right? To find Q. So then that would be 1/60. But we don't want Q, right? We don't want that allele frequency. What we really want is the chances that this dad right here is a carrier. So what we actually want is 2Q. Okay, that's the trick that everybody forgets that I always forget. So you want to know 2Q. So you want to multiply that 2 times 1/60. So you get 2/60, sorry. 2/60, which equals 1/30, okay?
All right, I get it. And then you have 1 for the child, and that will give you 1 over. Okay,
Yep.
I got it.
So 1/30 for dad, times 1/4 for mom times Mendelian frequency of an autosomal recessive trait. So they'll give you the incidence. It'll be this big number. It'll look familiar, like if you squared or take the square root, you know, you'll be able to get it. So yeah, so just remember, let's just do to make sure we have this straight. Just whenever they give you the incidence, right? They'll give you the incidence. What's another one? 1/2500, right? Your immediate step is to find Q. So Q will equal the square root of 1/2500. So Q will equal 1/50. We don't want Q. We never really want Q. We always want 2 times Q. So which equals 2 times 1/50, which equals 2/50, which equals 1/25. Okay? So just never forget,
All right,
we're looking
thank
for
you.
carriers,
Thank you.
carriers, carriers. So carriers
Yeah.
always multiply by 2.
Yeah, but someone in the chat asked if you can go over the mom one more time, like the mom, like the
The
one
mom,
for the
okay,
mom.
sure. Okay, so we had the aunt that we're interested in. We know her husband came through and he was from the general population. Now, the aunt has a sister who's married and they have a kid. And this child is a carrier for cystic fibrosis. So what is the percentages that the child is a carrier for cystic fibrosis? 100%, right? We're telling you that they have the small a. So we know this child is a 1. The 1 is definitely a carrier. Now we want to ask, of these two, what is the possibility that this child got this little a from mom, and what's the possibility they got it from dad? It's 50-50, right? We don't know their genotype, so it has to be 50-50. So the little a could have came from here or could have came from here. So we'll say there's a 50% chance it came from mom and a 50% chance it came from dad. Okay, so now we at least know the mom of the sister, right? So when we go up and we do this, we know that, right? So this sister right here that we know is now 1/2, and her sister, they came from the same parents, right? These two. We know that fraternal twins, I'm sorry, not twins, sisters, brothers, sisters, siblings always share about 1/2 of their DNA, right? So we know that this person is also 1/2. So again, y'all haven't got a ton of practice with this because y'all don't need to be able to do this because this is out of the scope. It really is, because when Lindsey and I were down here when we had to do this and we had paper and we went through crazy pedigrees, like crazy 6th-generation pedigrees where we had to do this math out, but they're not doing it for you guys because y'all don't have paper. But the point is, we needed to figure out this person, right? Over here. So we needed to figure out the sister to get to the child, or to work backwards. So now we just, the way to do this is you multiply through the pedigree, okay, to figure out what this person is over here. So you multiply the kid that is the carrier times the mom who could have gave her the gene times the sister who's 1/2 the same DNA. Okay. Yes, so right, look, so we can't use the 2/3 or 1/2 rule because we're talking about carriers. The 2/3 and 1/2 rule assumes that somebody in the pedigree has the disease. Okay, so again, this is not a rule or anything. This is just longhand working out the whole thing. Okay, so this is not a trick. This is just you having to figure out. That's why I think it's out of the scope. But remember, those rules we looked at, those rules look, they assume we're talking about sibling with the disease, a child with the disease. We're not talking about carriers. Carriers make it a lot more complicated. Okay, so I hope that made sense. But again, I really don't think y'all will get into anything that complicated. All right, anything else? Confused y'all enough? All right, well, we'll go ahead and stop the recording. And if y'all need anything, y'all feel free to reach out and I'll get this posted in a little bit. All right, good luck, guys.
Good luck, guys.